skull-base approaches and what all can be done endoscopic, expanded applications and all. And Rajat, let me know when to speak 10 minutes before, when to stop. Hello? Hello? Hello?
Am I
Hello?
audible?
Yes, Rajat.
हाँ सर हाँ सर
So let me know when to stop 10 minutes before, huh?
सर 6 till 6 o'clock.
Okay, no issues, no issues. So we'll go ahead with the important issues on priority. So are you getting the audio, video picture there?
Looks, yeah, we are getting the endoscopy picture, boss. Looks like very
Cadaver is good.
Yeah,
fresh
ultimately
cadaver.
got a good cadaver.
Yeah.
And see, if we look at the, we quickly just touch upon the anatomy of the endoscopic anatomy. If we put a 0-degree endoscope in the nose, in the medial wall all along is the nasal septum, we all know. Lateral wall is the area of interest for the endoscopic surgeons. Raju. So our area of interest is a lateral wall. And lateral wall, what you see with the 0 degree is a lot of prominences and depressions in the lateral nasal wall. So the first prominence in the lateral nasal wall is this inferior turbinate. This is a bone which is a separate bone than maxilla. There's a separate bone, inferior turbinate, in contrast to the other turbinate which are part of ethmoids. This is a separate bone. And this inferior turbinate is an important anatomy. It contains some vascular tissue as well, which responds to allergy and inflammation. And below the inferior turbinate is a space enclosed. If I go into it, in the roof of this space, see there, can you see some opening?
We can see, sir, yes.
Yeah, this is the inferior meatus under the inferior turbinate, and we see this opening in the top of the inferior meatus. See the location of this opening. This opening is the opening of lower end of the nasolacrimal duct, which opens through a valve of Hessner's.
Yes sir.
And this location of this opening, if you look at it, in terms of centimeters distance, this is almost a centimeter behind from the anterior edge of the inferior turbinate. See there?
Yes sir.
And in terms of location, it is situated at the highest point of the inferior meatus.
Right.
See, this is important to understand because a lot of people, nowadays it is almost not very frequently practiced, but earlier people used to do a lot of intranasal antrostomies through the inferior meatus.
Right.
So this opening is at the highest point in the inferior meatus, a centimeter behind the turbinate. Even if you do turbinate resections or anything, this is far preserved because the opening is not towards the turbinate, opening is in the lateral bony wall. And this lateral bony wall is formed by maxilla. Inferior turbinate is a separate bone. So this is inferior turbinate and inferior meatus. This inferior turbinate goes all along behind and ends just before the choana. See this?
Yes sir, yes.
Behind is the choana. Through the choana, if you see in the nasopharynx, there are certain important, again, protuberances. The most important one is the Eustachian tube orifice, the pharyngeal end of the Eustachian tube. This is the cartilaginous end of the Eustachian tube. We have seen the bony end of the Eustachian tube in the middle ear in the previous session. This is cartilaginous end. See, 2/3 of the Eustachian tube is formed by cartilage. And this opening is governed by several muscles. See, this is Eustachian tube cartilage, torus tuberis. It forms a prominence and it is governed by certain muscles, the levator and the tensor pallati, for the function of this Eustachian tube which delivers air in the middle ear. So, and just behind the cartilage in the nasopharynx is a space going far laterally. See this far laterally, almost for more than a centimeter, ending far laterally towards the parapharyngeal space that is known as fossa of Rosenmuller.
Right.
So, Eustachian tube orifice, cartilage, and this is fossa of Rosenmuller behind, which is an important landmark in certain situation when you are working around the Eustachian carotid artery. This is within a centimeter or so proximity to the parapharyngeal carotid artery, so can be used as a good landmark. Now, this Eustachian tube again is a great landmark for the carotid. We have seen in the otology the Eustachian tube was medial to the carotid, lateral to the carotid. So Eustachian tube is lateral to the carotid, and same thing stays correct here as well. This Eustachian tube runs laterally to become the bony tube opening in the medullary cavity we have seen before. As long as it goes towards the middle ear, this cartilaginous tube forming the bony tube, all the way it remains anterior to the Eustachian tube. So in the middle ear, Eustachian tube covers the carotid artery, that is Petrus carotid, and here the Eustachian tube goes laterally, covering the carotid artery. So Eustachian tube again covers the carotid artery, protects the carotid artery like mother's lap. This inferior turbinate, as I said, is a separate bone, is a useful tissue sometime for reconstruction as well. And this inferior turbinate is uniquely supplied by some vessels which are branches of sphenopalatine, predominantly by the sphenopalatine. We will see later on the artery, sphenopalatine artery, the course, how it comes in the nose and how it supplies the various structures. So one of the branch, see this is the maxilla, behind the maxillary sinus is the pterygopalatine fossa, and where the artery comes out here. It divides into multiple branches. The one goes to the middle turbinate. This branch goes to the middle turbinate, and that's how some people even use the middle turbinate as a flap for reconstruction of the skull base in case other flaps are not available. One branch goes anterior to the sphenoid to supply the nasal septum, and that ramifies into the entire septum and joins other vessels to form a strong vascular network, which makes it one of the most preferred flap for the skull base reconstruction. It has revolutionized. See the entire science of endoscopic skull base surgery, one of the biggest credit goes to the success of that, goes to this flap, which was devised by our two ENT colleagues, Haddad and Basagestegui from Argentina. They did a lot of angiographic studies to see this vessel, its branches, its anastomosis with other vessels, and found it to be richly vascularized tissue, can be used for reconstruction. It has revolutionized. Revolutionized means earlier when this endoscopic skull base surgery started, even the small skull base defects were looking challenging. The fear of CSF leak was too high, and CSF leak once happens can ruin everything. After this Haddad flap, now even we can create, or we create defects in centimeters, and we can reconstruct very effectively by this vascularized tissue. And now there are a lot of modifications of the Haddad came in, we will discuss once we come to the reconstruction part. So this inferior turbinate here gets another typical, its main blood supply from the sphenopalatine, which runs through the inferior turbinate bone, not only through the mucosa or submucosal tissue, but the vessel runs through a canal in the bone coming anteriorly, and here it joins or anastomoses with some of the facial artery branches come from the lateral wall. So this is the main vessel of the turbinate. Sometimes you do turbinectomy, and this vessel becomes the source of bleeding if not coagulated perfectly. Then the next important structure in this region, or for the sinus surgeon, the area of interest is this middle meatus. This middle meatal complex, you see there are lots of protuberances and depressions. And why it is important so? Because major, paranasal sinuses drain in this region in the middle meatus. So this middle meatal complex is defined by certain anatomical structures. The biggest in this region is the middle turbinate. This middle turbinate is unique in terms of its orientation. What we see the proximal first part lying in the sagittal plane. Then this turbinate, see this turns laterally here behind the bulla. This is bulla ethmodalis, retrobular recess, and this turbinate goes laterally to insert on the lamina papyracea. This is the second part of the turbinate known as basal lamella. This is important anatomically as well as physiologically as well, as all the paranasal sinuses anterior to this turbinate, basal lamella, drain anterior to it. This is the maxillary sinus, the frontal sinus, they all drain anterior to it. And the third part of the turbinate is lying in the axial plane. See the first part in the sagittal plane, second part in the coronal plane, and third part in the axial plane, going all the way to the perpendicular plate of the palatine bone or even to the roof of the nasopharynx. So that's how this three-dimensional orientation contributes to its stability. Now coming anterior to it, see this lateral wall, entire lateral wall, the only mobile structure in this entire lateral wall, all the way from here to here, is this bony plate. This is very, very important entity, and this is known as uncinate process. It's a part of ethmoid bone. Uncinate process is important to understand the sinus drainage pathways. Why sinus surgery has become popular? It's because of research work from Stamberger and Messer-Klinger. What they observed by their, studies using lots of dyes, that how the sinuses drain through their ciliary activities through the natural ostium, not by the gravitational method. And that's how the sinus surgery has become popular. So this uncinate process is a bone. It covers the infundibulum from anteriorly. Infundibulum is a three-dimensional space where the maxillary sinus opens, ostium opens. So this has a lot of bearing on the success of the sinus surgery, how you deal with it. This upper part of the uncinate, by and large goes, turns lateral to insert on the lamina papyracea. In almost 97% situation, it happens like this. In uncommon situation, it may insert on the turbinate medially, it may insert on the skull base, and that you have to be very, very careful then, so that you don't damage the skull base or turbinate or get a CSF leak. Otherwise, by and large, it goes laterally to insert on the lamina. This inferior portion, see this goes variably horizontally, this is a horizontal plate, goes variably, either ends in the inferior turbinate or goes up to the perpendicular plate of the palatine bone. This uncinate has to be thoroughly removed to prevent a lot of, sinus surgery failures, lot of issues, recirculation issues, inadequate clearance of the region. So uncinectomy is the first step in sinus surgery, should be adequately done. We'll show it. The next behind uncinate is this hiatus, this semilunar hiatus, and behind that is the bulla. Bulla is an ethmoidal cell which goes above right up to the skull base. Majority of the cases it goes up to the skull base. We'll show how it is important, how it covers protects the anterior ethmoidal artery, and how it has to be dealt with. But this is an important anatomy. So this is middle meatal complex. Inferior meatus we have seen. Nasopharynx we have seen. Now if we go medial to the middle turbinate, this is nasal septum, and behind comes another turbinate. This is superior turbinate. This is important anatomy again. See this space, sphenoethmoidal recess, and see between the septum and the sphenoid, this is the ostium of the sphenoid sinus. This is very important to understand because nowadays sphenoid sinus has become the center of universe for the endoscopic skull base work, and we must understand the anatomy of the sphenoid sinus and surroundings. Surrounding of the sphenoid sinus are lots of critical neurovascular structures, lot of cranial nerves, carotid artery, optic nerves. So many things are in relation with the sphenoid bone. So we have to be well versed thoroughly with the anatomy of the sphenoid, particularly to understand this science better. So now, to begin with, our course will be.
Sir, is this middle trabinate a concha bullosa by the safe?
Doesn't look like. Doesn't look like. I am not very sure, but concha bullosa is confirmed on radiology, but it doesn't look like. See,
Okay,
it doesn't look
maybe
like.
paradoxically bent.
Yeah. But concha bullosa is a finding. It's a radiological finding. You have to confirm in radiology where the turbinate
It looks
becomes
like a pregnant
pneumatized.
belly.
Yeah, when the turbinate becomes pneumatized. So now quickly, we'll first go ahead with the steps of functional endoscopic sinus surgery, how one can accomplish by utilizing landmarks by landmarks, accomplished by, very, very safely without giving complications, because this area, in this region, the margin of safety is very less. Orbit is in close proximity here, and one of the biggest anatomy of the landmark for the medial wall of the orbit is in the upper part of the uncinate, which is in closest proximity, I will show. Then the skull base is in closest proximity with all the paranasal sinuses, the upper paranasal sinuses particularly, and the sphenoid, the carotid artery, optic nerve, and so many other crucial structures are in close vicinity. So even a millimetric deviation, disorientation can lead to fatal complications. So you have to be very, very careful. And this is a surgery of landmarks. You at each step, you have to identify landmark for the next step so that you can accomplish very, very safely. So my first step of sinus surgery would be to remove this uncinate process. See this? If I go behind the uncinate, this is the uncinate, this is the infundibulum, here is the infundibulum, and see this. What I see for the junior colleagues, take the instruments under vision and bring the instrument under vision. So you don't traumatize the opposing surfaces, which can lead even to synechia formation, mucosal damage. So go open up the uncinate and turn it little down. See anteriorly what is the prominence. Eustachian tube is this. Anteriorly is the prominence, that is prominence of the nasolacrimal system. So that is immediately anterior to it. See now, I'm biting through the uncinate. Keep biting through until you reach the hard bone.
We call it a passer window.
I can find the hard bone. Yes, Amit. See, I have bitten through the uncinate.
Yes, sir.
And made a window. This was initially described by Parson as Parson's window.
Parson.
See, what I have done is a middle meatal antrostomy. I have opened the maxillary sinus. Now widening, and for the adequate widening, see this?
Yes, sir.
I can take away this lower horizontal part either with my shaver, or I can use a through biting as well.
Through biting.
Whatsoever you are used to. But it should be a sharp instrument so that you don't pull the mucosa. See, there is a mucosa preserving surgery, functional endoscopic sinus surgery, and function is served by mucosa. So mucosa has to be preserved, and see the role of this shaver microdebrider. It cuts through the mucosa sharp, it doesn't pull it, and it preserves the mucosa. See this? Now this middle meatal antrostomy, how much to be enlarged depends upon or dictated by the pathology. If you have a massive fungal disease, AERD, or anything which dictates long-term surveillance or long-term steroid irrigation, you need to keep a enlarged middle meatal antrostomy so you can follow up adequately and you can push the steroids thoroughly. In a minimal pathology, you don't need to enlarge too much. So enlargement has no definition. Whatever I have done is a reasonable one. If you want to enlarge further, I can remove this posterior wall. This wall up to the posterior wall. This wall I can further remove and flush with the posterior wall. I can
But
flush with the
sometimes there
floor.
is a small vessel there, sir,
Pardon?
on the posterior wall. Here there is a small vessel.
This one?
Uh,
No, vessel will
Most of
come.
the
This is
time there is
mucosal fold. Vessel definitely will come deeper, and that will be
yes.
greater palatine. But this is the mucosal fold only. Yes, vessel will come same like this. So in further, if you want to enlarge, you can flush with the nasal floor as well. Or you can do a complete middle meatal and middle medial maxillectomy in case you need a, longer follow-up for the lateral regions or for gravitational drainage in certain conditions like cystic fibrosis or something where the ciliary activity is hampered and you're totally, are at the mercy of gravitational drainage. So, suction. So, this is about the middle meatal enterostomy. This is the first and the simple step one can accomplish by many ways. This is the simplest version what we do in our practice. Uday, great. Now the second step, this is very, very important, and you must look at the CT scan also, that how far this uncinate upper portion is to the orbit. This is the closest structure to the orbit. So what you can do simply in the safest manner, go behind and fracture anteriorly, away from the critical structures behind.
Yes, sir. And then we can debride it.
Yeah. So fracture anteriorly, that is the safest mode you can think of. You can debride, you can use through biting. सिर पकड़ना पड़ेगा इसका यार एक बार. So I can use the shaver. Now see what I am showing, how close it is to the lateral wall, lateral limit of the entire sinonasal corridor. See, the moment you remove the uncinate, you reach to the lateral limit of the entire sinonasal corridor. What an amazing landmark you get once you remove it thoroughly. And lateral limit of the sinonasal corridor is orbit.
Orbit.
See
Lamina
this?
papyrus.
This is lamina papyracea. See how one can easily reach the lamina papyracea in no time. See, this is the lateral limit. Remove the uncinate thoroughly. And this becomes a source of problem if you are not aware of it. Many a times, the orbital is too medialized. Your uncinate is deformed. Your sinus is hypoplastic, making the orbit more medial. And if you are not aware of this and go and removing the uncinate like this, you can easily make an orbital entry, that too in the beginning of the procedure. And that is disappointing.
Yes, sir. We have to do the CT scan to see if the lamina papyracea
Yes,
is there.
every time. Just thoroughly look at the CT scan, three-dimensional CT scan, dynamic CT scan in the DICOM.
And the portion what sir is removing is very, very important if you want to access the frontal sinus. The upper part of the uncinate.
Sir, I think the agarnesia is also gone.
Junction of exit.
Now I am going to show you at this step out of our experience how to
This is
deal
very,
with
very
the frontal sinus.
Yes.
Simplest way to deal with the frontal sinus that can never fail, something like that. N number of techniques people have shown and complicated the sinus surgery. I tell you the simplest version of frontal sinus work. See now what I have done? I have gone to the level of the axilla. See what I have opened up? Axilla.
Agarnesia.
Axilla I have opened up. This is axilla. See what the landmarks we are using are the simplest one can pick up. Anybody can see the axilla well?
यहाँ पे point किया हुआ है.
Anybody can find the axilla?
Right.
And I have opened up the axilla thoroughly. See, this is the bone laterally. That's the turbinate medially. I have done middle meatal enterostomy. My bulla is intact. And at this point of time, I'll take 70 degree to look up. See frontal sinus is one which makes the life difficult, which people are scared of handling, end up doing many a times incomplete job. To shatter your all fears, the technique I am going to show you for the frontal is never, something
It's already open.
already. Yeah. This anatomy is
So
straightforward.
when you were clearing the axilla, the agar gone, agar was gone.
So this was the simplest situation of frontal, but
What can
our aim is to understand the concept.
Right.
See with the 70. Number one, why I choose 70 degree at this point of time? See this, my bulla is intact.
There is a question, there is a request that please show how are you handling 70 degree by external camera and yeah, please.
Yes. Can bring the external
individual-
camera and
individual-
PIP. PIP and external camera, please.
Yeah.
External camera in main and PIP the endoscopic picture.
Right.
Can they put PIP? पूछो ना.
Yeah, please show. Yes, sir. We can PIP endoscopic view.
So handling the 70 degree,
Yeah, endoscopic view of PIP, please.
yeah, they are doing something. So why it is important? 70 degree gives you advantage of accessing to the inaccessible area. You are looking straight, but what the endoscope is pointing is 70 degree up. So you have to get oriented to this kind of, picture. One has to get used to 70 degree, but once you get used to, this is amazing. It can show you hidden areas which are otherwise difficult to see with the regular endoscope. I have PIP? So let me know when the PIP.
Star Audio Visual, can you do PIP of endoscopic?
Now see why I have taken 70 degree here. I need to do the frontal
Ismail,
sinus work.
Are you there?
I need to do the frontal sinus work, and I have certain challenges, fears with the frontal sinus work because of its anatomical
You got it,
location.
sir, now.
No, I mean,
Frontal sinus is high up situated. It is situated so anterior-superiorly, and you can't see with a 0 degree in a linear
Yes,
fashion.
yes. Now we got it, sir, yes.
now it's okay.
Are you getting the picture both?
Yes,
Yes,
both,
yes,
both.
yes.
Sir.
So now, how to handle 70 degree like you were asking? See 70 degree, you hold it. Can you see?
Yes.
Now, how to bring the instrument? That is important. Your instrument should be followed by telescope. Can you see?
Yes.
Instrument should be in front and telescope should follow it while getting in or getting out.
Yes, so this is with angled and it is
Simple.
opposite with the 0 degree.
It cannot work when your instrument is behind. That is the biggest mistake. So bring your telescope to the nasal opening, anterior nares, and bring your instrument in and follow both the hands together. See this? Believe me, once you get used to, that's how cadaveric dissections are important, to get used to, instrumentation, can get used to identifying structures. See this? So again, just bring your endoscope at the opening, bring your instrument in front and follow it with the endoscope. It's not difficult, it's a matter of getting used to.
Yeah.
Okay? So
Yes,
why
sir,
I
yes.
chose 70 degree? One is the strategic location of this frontal sinus. It is so high anterior-superiorly. Unlike other sinuses, you can't see through the linear endoscopes. Number two, its close proximity to the skull base. Skull base is in close proximity. If you are not oriented,
Yes, that's a curvy bone.
one can damage the skull base even. So you have to be careful. You are close to the orbit. Slightest orientation can push you in orbit laterally, and that's a disaster. Then while widening the frontal sinus, a lot of people have a fear of damaging the anterior ethmoidal artery. So in order to shatter your all fears, 70 degree works best. Number one, See my medial limit as terminate. This is the middle terminate which is going high up. See high up here, and high up it goes and inserts on the cribriform plate at the junction of medial and lateral lamella. This terminate is attached at the junction of medial and lateral lamella of the cribriform. So as long as terminate is capped in the medial wall, medial limit, and make sure you don't cross it medially, your skull base is safe. Similarly, see this is the lamina papyracea. This is lamina papyracea. If you respect this and keep in eye, keep in your view and don't cross it, don't violate it laterally, your orbit is safe. This 70 degree works to keep both the medial and lateral limits together in view, so you don't cross it, which is not possible with the 0 degree. Third is anterethmoidal artery. Now see why I kept the bulla. Let me show you. See, first see the orientation. Our frontal sinus is up there. This is the most favorable situation we can assume. See this? Why I showed this technique is use 70 degree, find the axilla. Find the axilla, stay between the lateral and the medial limit. Stay on the axilla, 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 and if you go follow the axilla, this is the beak. This is the beak between the medial and the lateral limit. Start from the axilla. This is beak, the thickest bone in this region. Follow the beak where the beak ends in the frontal. Whatsoever
this
the
is the most
cellularity
important
anatomical variation is. Simplest of all techniques
The
to
frontal beak.
deal with the frontal sinus is the beak. This is a God's given natural landmark. Beak forms the floor as well as the anterior wall of the frontal sinus. So if you follow the beak, you look at the CT scan, the sagittal section, follow the beak where the beak ends in the frontal sinus. Now whatsoever the anatomy inside, whatsoever the frontal recessed cell, there are a variety of cells which can complicate. But if you follow the beak, this is never going to miss your frontal sinus. It has to be frontal once the beak ends. Another beauty is beak is a solid landmark which is rarely gone even in the multiple revisions unless somebody has drilled the beak. So majority of the time until the draft is done, beak is always available as a most reliable landmark. Even if all other landmarks lost and you have a beak, you can still accomplish everything. So this is a very, very important landmark, and simplest way to, enter into the frontal in the beginning is follow the beak. And how to follow? Find the axilla. Axilla you have seen, you can easily find. Stay between the lateral and the medial limit and go here inside. Third is about the anterethmoidal artery. See, with 70 degree, we are looking up anteriorly. Looking up, our direction of instrumentation, direction of endoscope, everything is anteriorly placed. Anterethmoidal artery leaves the orbit, runs through the ethmoidal reef and enter into the cribriform plate. But now see, I will show you in CT scan as well. This is the beak. From the edge of the beak to the anterethmoidal artery is never less than 2 centimeters. So once you work anteriorly directed with instruments, endoscope, everything, your anterethmoidal artery is automatically left behind. That is in the different trajectory all along the skull base in the posterior part. We are working far anteriorly and anterethmoidal artery is far posteriorly. Further, if you leave the bulla intact, that covers the anterethmoidal artery if it goes to the skull base. Majority of the time it goes to the skull base. Now see this bulla ethmoidalis. Let me show you the relationship. See, at this stage we are not able to see the anterethmoidal artery because it is very well protected by the bulla. So that's why we keep this bulla intact majority of the time. Now, if I fracture this, you will see how it was protecting the artery. See, my artery is here. Artery is here. Let me show you through cut there. See, until now no artery was seen while looking at the frontal. Now I am taking over this bulla. I have seen the artery behind. Let me show you. Now, my artery is here. Here is the artery. See this. This bulla is going beyond. This is the artery. This is the level of the skull base, and bulla is going anterior to that, anteriorly to the skull base. So majority of the time, bulla goes to the skull base, and artery remains covered by it behind. In uncommon situation when bulla doesn't reach the skull base, this ends here behind the artery you will see in the suprabular recess. Then is something you can see on the CT scan and you stay more careful. Otherwise, this artery is like something which covers and protects the vessel. So every time you have to take advantage of some or other landmark. Now, let me remove this part of the bulla to show you further at the skull base. Let me remove this bulla. Bulla, dena.
Satish, can I interrupt you for a moment?
Yes, please.
Yeah. So this technique of identifying the frontal sinus, would it work in all types of frontoethmoidal cell situation?
Frontoethmoidal?
A cell situation, whether there are type
Yes,
of
yes,
cells.
by and large. Because even if you have multiple cellularity, if you hug the beak, you are never going to get lost. You may see multiple cells underneath, but you keep hugging the beak, it will take you right to the frontal. It works every time. Now see, I have removed the bulla, and now you can see the much better picture of the artery. See my vessel there? Can you? Reverse there.
Yeah, yes, sir.
See this.
Yes,
This is the vessel.
Sir, there is one question that how
Go
do
ahead.
you identify the supraorbital cell versus the frontal? So,
See,
can you just
I have
enlighten on
reverse.
this for
Yes,
juniors?
important thing.
Yeah.
See, I have already answered that. Supraorbital cell is a posterior anatomy. Supraorbital cell is never close to the beak. Supraorbital cell is a quite posterior anatomy behind the frontal sinus. The moment you open the beak, hug the beak and go inside, can never be a supraorbital cell. Supraorbital cell is a posterior anatomy. When you go hugging the beak, it cannot be anything else than the frontal sinus.
Yes. And sir,
Now,
the
where the supraorbital cell in this case, suppose in this situation, if there is a supraorbital cell,
yeah,
what should be the
one
location?
inferior. This one, yes, sir. This is the supraorbital
Yes.
cell, yes.
Here. See this. Let me show you. This is frontal sinus.
So the
This is
frontal
the
sinus will have
anterior
bulge
artery.
also, sir.
Anterior
Bulge
artery.
of the frontal dura will be seen on the frontal lobe.
Yeah. This is the prominence of the frontal lobe, posterior
Yes.
table.
That's always
This is the
there.
anterior artery.
Yes,
And
sir.
my bulla was coming like this and attached to here. See this, this was the
Yes.
bullar attachment, which covered the anterior artery. Now this space anterior to the anterior artery is, this is the suprabular recess, and if it goes laterally to pneumatize,
Then it is called
it goes above the orbit. That's the orbit. See this?
yes,
It
yes,
goes
yes.
above the orbit and pneumatize this orbital plate of frontal bone. That's the orbital plate. Once it pneumatizes, it is known as supraorbital cell, but it is behind the frontal sinus. And sometimes supraorbital is an advantage if you look at the CT scan. Once you look at the CT scan, if there is supraorbital cell, the anterothymoidal artery is already posteriorly displaced. So anterothymoidal artery is always behind the supraorbital cell. Suppose this cell supraorbital would be more over-pneumatized. Over-pneumatized, this artery would have been further behind. So supraorbital cell is sometimes can be utilized as a landmark. Now see laterally,
Dr.
this is
Manoj,
lamina papyracea which I am breaking. Can you see? Very thin bone.
सर
Yes, please.
सर ये वाला ओरिएंटेशन आप 0 डिग्री से एक बारी दिखा दीजिएगा.
हाँ, yeah, sure. Give me 0 degree. 70 degrees, my favorite scope to carry out after the initial work, is the most versatile one. Now see, with a 0 degree. Yes. See, my frontal is above. Frontal is above. This is lamina papyracea, which I am breaking. See the lamina papyracea? That's the anterothymoidal artery. That's the suprabular shallow recess cell, suprabular cell, and this, if further pneumatized, leads to the supraorbital cell. Now, there are all fancy named cells in this region. All are anteriorly are the frontal cells, Kuhn cells, type 1, 2, 3, 4, complicating the frontal sinus axis. Supraorbital cell, again complicating frontal sinus axis. Then medially the, septal cell, intersinus septal cell, again obliterating the sinus axis from medially. So all you have to see on CT scan and accordingly deal with it. Now, this artery again is a source of, unnecessarily terror. People get frightened. Let me show you something about the course of this vessel. I am removing this bone to show you the course. Can you see the vessel better? Just to show you the course, how this vessel comes out of the orbit. Can you see? This vessel is a branch of, anterothymoidal is a branch of ophthalmic artery. We'll show you ophthalmic artery, how it arises from the internal carotid as a first subarachnoid branch of internal carotid. We'll show you the course of the internal carotid from this side.
Sir.
Yes?
Sir, in this place, could you please show one's anterior ethmoidal artery flap for septal perforation?
Yes, sure. It's one of the versatile flap, even become our favorite also. So easy to use and reliable. So we'll show you. So to understand that flap, first let's understand the course of the artery. So this anterothymoidal artery is a branch of ophthalmic artery given off in the orbit. In the orbit, it is given off where? Let me open up this. Let me open up the orbit inside to show you where exactly this artery is given off and runs through. See, I am in the orbit. This is the orbital fat. I am teasing out the fat to show you the muscle. Can you see the muscle below?
Right.
What is this muscle?
Lateral rectus. Medial rectus.
Medial rectus. This is medial rectus here, and can you see this muscle going up? This one?
Superior oblique.
Superior oblique. This is superior oblique. This is medial rectus. This muscle, this artery is given off and in the orbit here and comes out of the orbit. See this how it is coming out at the confluence of superior oblique and medial rectus muscle. This anterothymoidal artery. This contains blood from the internal carotid system. Now, leaving the orbit, this artery runs in the roof of the skull base. Can you see this here? Roof of the anterothymoid.
Right.
And can you see the thin bone here?
Right.
Very flimsy. Very thin. The thinnest bone of the skull base here, entire skull base.
Cribriform.
That is the lateral level of the cribriform. The thinnest bone of the entire lateral skull base is here. And this artery pierces this thin bone. This artery this artery pierces this thin bone, lateral lamella of the cubiform. See this artery where it is going?
Yes, you
Can
can
you
see.
see the oblique course of the vessel?
Right.
So this way, this artery leaves this and enter the olfactory fossa of the brain. See this.
Sir.
Some branches also. That's the dura. It pierces. So this artery runs through multiple compartments. The first compartment where it arises is the orbit. From the orbit it runs in the roof of the anterethmoid. That is second compartment. From that it pierces the lateral lamella to enter the intradural space, that is olfactory fossa of the brain, the third compartment, eye, sinuses and brain. And in the third compartment, in the olfactory fossa, there, it runs anteriorly on the bone forming a sulcus, olfactory sulcus, and gives off a branch to the fox cerebri. Fox cerebri arises from the crista, and this is supplied by the anterethmoidal branch. So there in the brain, it gives off a branch, anterior falcine artery. And then coming anteriorly, it comes off in the nasal cavity back. That is fourth compartment. So amazing the course. See the artery going there in the brain, coming anteriorly, and then the fourth compartment, it comes again in the extracranial part here, in the roof of the nose. Here this vessel comes again, see the branches. Can you see? Hello? Here this vessel comes again back in the nose. These are the branches of anterethmoidal artery. See this? Hello? Hello? Am I audible?
Yes, yes, yeah.
So that is the fourth compartment. And after supplying this upper part of the septum and the upper part of the lateral nasal wall, both it's supplied by anterethmoidal artery branches. Anterosuperior part is supplied by the anterethmoidal artery in the nose. So supplying both the surfaces, this and this artery goes up and out onto the dorsum of the nose. It comes out on the dorsum, comes out between the space between the upper lateral cartilage and the nasal bone on the dorsum of the nose and run down on the dorsum till the tip of the nose. That is the fifth compartment. So that's how this artery runs, and it has its own implications. The biggest in the sinus surgery, why we are scared of, why everybody talks about this vessel, so feared of this. The reason is, if this vessel happens, while dealing with this, if they happen to get transected here, close to the exit from the orbit, this can retract into the orbit. And then if it retracts and keeps on bleeding, orbit cannot accommodate that much blood. Orbit is surrounded by bones all around. Even a 5 ml extra blood can be good enough to compress the orbital nerves and vessels and can lead to blindness even. It can lead to proptosis, blindness, and can fix the eye, because this artery can keep on bleeding and can give this rise to complications. So fear number one, if this artery happens to get transected close to its exit from the orbit. Fear number two, this artery is close to the lateral lamella and the dura here. If this artery happens to get injured here close to it, even dealing with the bleeding can lead to dural injury and CSF leak. That is the concern. Bleeding is never a concern with this vessel. This is a tiny vessel. We deal with carotids and much bigger vessels in our practice. This is an average diameter of 0.93 millimeter. This is hardly anything where the bleeding can be a concern. So, how can you prevent this during sinus surgery? That's how what we can infer out of this knowledge, that how this artery runs through.
Satish was like, in this case, the artery is almost in the skull base, but many a times it is in the mesentery.
Yes.
And with extensive polyposis, it is sometimes we are not careful, we can injure it with the debrider while removing the polyps.
Yes, yes. So that's what
Can be
our,
seen very well in the CT scan. Kennedy's nipple will be.
even if you the see in the CT scan, extensive raising, bleeding can, lead to this. So simplest way, while working in the vicinity of the anterior ethmoid here, define your lateral limit and medial limit and stay in between to work close to the vessel. On the extremes, on either side is the disaster. Even if you work in the middle of the course and even if you injure the vessel, what can happen at the most? It can bleed a little bit. You can take a bipolar and coagulate, put a Surgicel, Marocel, peg with something for 5 minutes, it will stop. But if it is injured on either side, can be a disaster, which I mentioned. So in a given situation when you are lost, you are not able to identify the artery, you have to remove the disease, define your medial and lateral limit and stay exactly in the middle of the course. So even if you injure the vessel, it's hardly an issue. That is the best way to get away from problems with this artery. I hope it clears your doubt.
Yes, sir. Yes, sir.
Now, this vessel. So regarding the flap, I'll come to the Hadad flap and all that, but once you have asked, this vessel comes down here and supply the upper part of the nose and ramifies down with the branches of the sphenopalatine artery, the branches of nasoseptal artery here, and makes good plexus all over here. Now there are multiple advantages of this flap you can use. First, it is superiorly based. You can easily use for the minor dural defects as a vascularized flap. You can use it as sometimes you leave a lot of raw areas after a drop procedure, you can utilize this flap to cover the raw area in the same vicinity. Simple. It doesn't take more than 5 minutes to raise this flap and apply. So what are the limits of this flap? Our posterior limit of raising or incision is the anterior limit of middle turbinate. See this? This is the posterior limit. You can make an incision in the line of the middle turbinate head and you can bring it down even it has good of anastomosis with here, you can take even the floor skin also. Floor skin. Anterior limit depends upon the region you are operating using this. Suppose you have a septal perforation. The posterior limit of perforation can be the anterior limit of incision. And posterior limit is same. Once you have elevated, if there is a perforation, elevate the entire skin, advance anteriorly and suture it there. That's it. So this is one of the most versatile flaps for the small to medium sized perforations, septal perforations. And our preferred flap as well for lining, for CSF leak, anything close to the anterior skull base. Now, this what we have done so far is the middle meatal antrostomy. We have done the frontal sinus work. We have done the anterioethmoidal skull base work. This is the orbit. Now, where is the post-ethmoids? Immediately, few millimeters behind the anterioethmoidal artery is the beginning of the post-ethmoidal cavity. Post-ethmoidal cavity is defined by the ground lamella inserting above to the skull base. I mentioned in the beginning, ground lamella is one anatomy which discriminates the anterior from the posterior group of ethmoidal cells. Got my point? So once you see the upper attachment of the ground lamella, behind that are the posterior ethmoids. And now see, this is the anterioethmoidal artery. The moment you see the anterioethmoidal artery, immediately behind the posterioethmoidal cavity starts. This is posterioethmoidal cavity. So anterioethmoidal artery runs through the posterior most part of the anterioethmoidal cavity. Now see, this is the artery, what I mentioned. The beak is above. See the beak there. From beak to anterioethmoidal artery is always more than 2 centimeters. While working at the frontal sinus towards the beak, if you are afraid of anterioethmoidal artery, means you are not thorough with the anatomy of this vessel. This vessel is more than 2 centimeters behind. So that is the biggest advantage of using the 70 degree in that region. Okay? So now, we have done anterioethmoidectomy. Now, the post-ethmoidectomy is another, important step next after that. So, post-ethmoids are where? Behind the anterioethmoids. The post-ethmoids are behind the basal lamella. Now, it looks simple to understand that anterioethmoids behind are the post-ethmoids and behind are the sphenoid. But they are never in the linear fashion, Every anatomy is different and you have to be careful, because the reason being, if I keep going behind for the post-ethmoids, if I am not aware of the entry of the sphenoid sinus and keep going behind, sphenoid posterolateral wall has a lot of tigers going through, and if disoriented can lead to disaster. So, our philosophy is, before doing a complete post-ethmoidectomy, you must know where the beginning of the sphenoid is, so that you don't cross your limit and go accidentally into the sphenoid, to stay on the safer side. So what I am going to do, see the maxillary sinus, frontal sinus, anterioethmoidal artery, orbit, middle turbinate. Now what can be done? What I will do, before doing a post-ethmoidectomy, I will define my sphenoid anterior limit first. Once I know the sphenoid anterior limit, I will make sure that I don't cross it to enter accidentally into the sphenoid. So now, how to enter into the sphenoid? How to look at the sphenoid anterior wall? See this. This is the anterioethmoidal cell. We have removed. This is the ground lamella. See, the turbinate is turning laterally to insert on the lamina. And this is the level of the roof of the orbit. See this? At this level, I'll make an opening medially. At this level. See this opening medially? And open up the tissue a little bit. Window. And the structure I come across, this is what the superior turbinate is. See the superior turbinate. Now, between the septum and the superior turbinate, see this medial trajectory, what you see exactly is the sphenoid sinus osseous. So easy to define, we have seen. See now, at this point, without doing post-ethmoidectomy, I have gone medial to the turbinate and lateral to the septum. I have already seen my sphenoid ostium. Now, to prevent the fear of damaging carotid artery and optic now, I know now where my sphenoid opening is. Carotid and optic cannot come anterior to the sphenoid opening. So now I will accomplish my post-ethmoidectomy keeping my sphenoid at the anterior limit. And before that, I will trim this lower 1/3 of the superior turbinate also to keep my frontal sinus opening in view. See my frontal sinus opening in view. Now, staying anterior to it, I can remove and do the post-ethmoidectomy without any fear. Now, I have no fear of damaging carotid optic as long as I stay anterior to the ostium. This is the safest way of, accomplishing post-ethmoidectomy. Post-ethmoidectomy, if otherwise, if you don't have a safety landmark, one of the dictum from the Mosher, 100 years back, what he said. Post-ethmoidectomy is the easiest way to kill a patient. You keep going behind and damage the carotid artery. So first safeguard yourself. See, my safeguard is the sphenoid ostium. I will accomplish entire posterior thymoidectomy, but make sure I will not cross the limit of the sphenoid sinus behind. I can do any damn thing staying anterior to the sphenoid.
Parallel. Looping.
See this?
So he,
Staying anterior to the sphenoid, I am pretty safe.
anything anterior to sphenoid side, this sphenoid cell is safe.
See anterior to the sphenoid.
Yeah. So he's
As
anterior.
long as you stay anterior to it, you cannot damage anything. Now, see this. If I keep going behind here, suppose, without taking this into consideration, without taking this, I may damage the lateral structure. So now I am widening the sphenoid. This is the time to widen the sphenoid and see something there. What is there behind?
Decent optic there.
Yes. So if you don't go by this approach,
And carotid also looks
yes,
decent.
yes. Suppose you don't take into consideration this safety mark, one can easily do a disaster. See this?
Yes, yes.
Imagine the example is right in front of you. But in any given situation, the carotid and optic will never come anterior to the ostium.
Right.
Guys, look at the sphenoid sinus. This is the anterior band of the internal carotid artery and see very well dehiscent.
Yes.
That is the optic canal, very thin bone over it.
LOCR.
That is containing the optic nerve and the ophthalmic artery, and this is the carotid artery, and this is lateral opticocarotic recess. And imagine if I had I kept
Can you show the medial OCR? That is also very well
yeah.
visible.
Had I kept doing like this without considering the sphenoid landmark, sinus opening as a landmark, and keep going laterally, I would have easily hit this vessel or the nerve. So never ever accomplish the posterior thymoidectomy beyond the sphenoid sinus, ostium, and then widen the ostium thoroughly. You will get to know what is there behind.
We can see sella also
Yes,
and clivus also.
yes, very nice. See, this is the carotid artery, this is the optic nerve, lateral opticocarotic recess, that is sella turcica,
Sella.
that is the clivus.
Clivus.
See this? And this is the medial OCR.
Yes.
This is lateral OCR, medial OCR.
Yeah.
Medial OCR.
So the
And,
sir, can you just tell us for everyone the space between which thing is what? Just where is MOCR?
Okay, let me show you again. OCRs are the landmarks which can be utilized. They represent the deeper structure inside, and during endoscopic skull-base surgery, they can be served as a good landmarks to protect you from deeper structures,
artery.
to orient you better. This medial OCR between the carotid and optic is because of pneumatization of the optic strut.
Yes, sir.
See this. Optic strut is what? Let me show you. This is the sphenoid sinus wall. This is the sphenoid sinus wall. This is the sphenoid sinus wall. Laterally is the clinoid process, anterior clinoid process, from where anterior clinoid process to the sphenoid sinus wall comes a strut, that is optic recess. Optic strut. If it gets pneumatized, you see the space between the optic and carotid gets deeper and deeper. That is what the lateral opticocarotic recess. So it serves as a good example, landmark for the optic and carotid. Now, medially, this is sella, this is carotid, and this is optic. At the confluence of this landmark is the medial opticocarotic recess.
Perfect.
At this keyhole, all the three can be accessed.
Right.
Below is the sella turcica.
Yes.
So this is about the full house face on one side. See this?
Yes, sir.
What you need to do is, step by step, open up the sinuses, respect the middle turbinate, and using 70-degree accomplish the frontal and the anterothoidal roof work, and completely skeletonize the skull base to do a complete work. Okay? This is how one can accomplish this, preserving the mucosa in a live surgical situation. Now, there are many more procedures which
sir,
can be performed. Yes, please.
There is a demand by Dr. Rajiv Pachauri, VDN neurectomy.
Median neurectomy, I will definitely show once I come to the pterygopalatine fossa. बॉस की तो मांग पूरी करनी पड़ेगी. So we'll show while I come to the pterygopalatine fossa.
Right.
Now see what I am showing, the medial wall of the orbit. See this? The thin bone and the periosteum. See this?
Yes, periorbita.
There are a lot of procedures one can nowadays with the expanded indications. We do a lot of orbital decompressions, optic nerve decompressions through the endoscopic approach, even dealing with the orbital tumors. All tumors medial to the optic nerve can be very well dealt with.
Yes.
Even the tumor inferior and lateral can be dealt with, but the easier ones are the medial ones. See this anatomy. See this anatomy.
So
How the orbital apex?
Sir, there is a question that how do you do optic nerve decompression? So from here, can you just show the optic nerve decompression, sir?
Okay, let me show you first that.
So you just follow this orbital apex, what sir
See
has
this.
shown.
You
Follow
yourself
that
see.
up
See
and
Amit.
then remove the bone. Yes.
Amit,
Yes.
can you see the
Yes, sir.
orbital apex?
Yes, sir.
Yes, yes.
See
Just
what I
follow
am
it.
doing. What I am doing. Fleck of the bone.
Crack up the bone and your optic nerve decompression.
This
So
is
you
the
are-
thick bone, thick tissue. Can you see?
Yes.
Right.
Annulus of Jain.
Annulus of Jain.
Annulus of Jain.
See, the simplest instrument is the periosteum elevator,
Now
flacking of the
that,
bone.
Sir, you are lucky,
Booster the
but
period.
sometimes the optic strut is, optic tubercle is very, very thick.
You can drill.
We need to drill it.
Yes, yes. No, don't think twice before drilling. Drill is a safe tool, I tell you.
Yeah.
See this.
Sir, hands are also steady.
I am just removing the bone of the optic now, and this is decompression.
Yeah.
And then when you are
People
doing
do-
optic nerve fenestration for the BIH,
Yes,
then
some
you
people
need to
do.
open the sheath
Open
and
the sheet.
Some people do for BIH and impending visual complications. See this. Let me show you that also.
Yes.
See, I am going towards the chiasma.
Right.
we have done a lot.
See this. In no time one can accomplish very, very safely. I am using the safest of the instrument, periosteum.
Right.
Yeah. See this.
Yes, sir. Yes, sir.
Now, the carotid is already dehiscent. See this?
Right.
This is optic strut which is pneumatized.
Right.
Now see the optic now. Now for the fenestration.
Sir, for all, so before that, show the ophthalmic artery.
Ophthalmic artery, I will show you the origin
Yes.
and I will show you how it enters the optic canal.
Right.
Ophthalmic artery joins
So
the
the
optic
medial
nerve.
and inferior surface.
Yeah, so let me first show you the fenestration. Let me
and
open
then-
up this sheath. See just put
Okay,
the knife there.
So the ophthalmic artery is medial and sometimes it may come inferior.
Mostly
to the,
inferolateral. Now see, I am opening the dura of this optic nerve.
Right.
See,
Right.
this optic nerve carries all the meninges along.
Right.
See, I am opening the sheath to show you the nerve proper. See this?
Yeah. The CSF is coming out.
Can you see the nerve? Yes, it carries all the
so
meninges.
that's how the CSF can
Yeah.
come out.
That's the optic nerve proper.
Right.
And for this is the safest way to do it is superomedially because your artery comes mostly inferomedial, inferolateral.
Right.
Yes, we can see the artery, sir. I
See
guess.
the nerve?
Yeah.
Now I will show you the artery as well.
Also, yes, yes,
The
yes.
origin of the artery and how it enters the canal.
This is first branch of
See the
carotid artery.
carotid?
Yes.
Yes, sir.
This is carotid.
Yes, yes.
Here was the clinoid process. This is the clinoidal segment. Now just after that,
Yeah, we can see the vessel.
We can see that.
That is a vessel.
it gives a branch which goes retrograde along the optic
Yeah,
nerve.
this one, yes, yes.
Yeah.
That's the vessel.
Yes,
Can you
yes.
see?
Perfect.
Yes, we
Yes,
can see
yes.
very well.
Let me
That
clear
is the
it.
reason why.
So that's
Let
why,
me make it little more clearer.
yes.
This is the first subarachnoid branch of the carotid.
intracranial ICA. Yes.
Right.
First subarachnoid branch, not first intracranial branch. See, this carotid artery.
First intradural branch of.
मेरा laptop on करना. I'll show you something to reorient everybody about the carotid artery. This is something everywhere. You operate in the nose, you operate in the ear, you operate in the, neck. Everywhere is carotid artery. And always confuse which segment what, why. Can you switch on my laptop, please?
Yes, sir. Yes.
So let me tell you something about the carotid artery. See this, first of all. Sorry, boss. That's the vessel. See, this artery is given off from the carotid here.
Right.
See the origin of the vessel. See this origin now.
Right.
See the origin above.
Yes, yes, we can see, sir. Yes.
And it goes along the optic nerve inferolaterally. See, very clear.
Yes.
All the way inferiorly, and just before the optic nerve pierces the globe, it gives off a branch central retinal artery, which is an end artery.
Yes, sir.
So see the course of the optic nerve. Very clear.
Yes, sir.
And the relationship with the ophthalmic artery, if you wish to do fenestration,
Yeah.
I would suggest you to do additional MR angiography to tell you exactly the course of vessel and relationship with the nerve.
So, sir, recently we have done one study showing the full course of optic nerve, right from the origin till the chiasma, over 20 cadavers, and we have seen the relationship with medial pterygoids, the medial rectus, inferior rectus, superior rectus, annulus of Jain, ophthalmic artery.
Super. Now, now, so this was all about the optic nerve.
Yes. So, before we go for carotids, can you just show the infratemporal fossa first?
Yes, I will come to it.
Yeah.
I will come in detail with the infratemporal fossa and carotid and this orbital apex region.
Right.
I tell you, this 1 square inch region, see this where I am pointing out. This 1 square inch region is the something which terrorizes the endoscopic surgeon. 1 square region inch means sella, clivus, carotid, optic, orbital apex containing all cranial nerves. Can you see all this?
Yes,
All the important structures are there, and if suppose it is a tumor invading this region, the fear is the damage of these vessels. If you have a Jain invading the cavernous sinus, you have a fear of bleeding, fear of injuring the carotid, fear of injuring the cavernous, and ultimately surgeon, if you are not well versed with it, anatomy, understanding, experience, you end up leaving the tumor behind. Any tumor invading in this region or arising in this region is always a challenge. So understanding anatomy of this region is the important aspect which I am going to highlight today. Secondly, the orbital decompression. See, recently we did 3 orbital decompression for thyroid orbitopathy. And earlier also we did, but sometimes the results were not, it was not about results, the after effects. The best way to do a orbital decompression for thyroid orbitopathy in case required is to do a 1.5 cavity decompression. See what I am showing. Remove this. Your periorbita is intact. See this?
Right.
Periorbita is intact. This 1.5 cavity decompression prevents the diplopia. Otherwise, when the orbital axis is shift, leads to diplopia.
Right.
See this. In the roof of the maxillary sinus, this is the prominence of the infraorbital nerve.
Nerve.
Right.
Infraorbital nerve. My 1.5 cavity decompression is inferiorly up to the infraorbital nerve and similarly medially for a centimeter or two. So what I am going to do now, this is my lateral limit inside the periosteum. Inside the periosteum, inside the periosteum, multiple cross edges, generally do with a sharp sickle. See this? Multiple cross edges and allow the fat to prolapse. See this? But keeping the sling of this periosteum, periorbita at the angle of the orbit. Your orbit will be thoroughly decompressed. See this? Your fat is going to prolapse anteriorly, posteriorly. But keeping the sling of...
Sometimes it is required to do if there is an injury to ophthalmic artery and, anterior ethmoidal artery and it retracts in the globe. Then at least this amount of work is required.
Right.
Yes, then also this decompression helps.
Yes.
Then decompression helps in two ways. If the orbital hematoma forms, the decompression helps in two ways. One is
To increase.
One is to drain whatever blood coming from the vessel to drain inside the nasal cavity. Got my point?
Yes, yes.
Another is
It prevents
you
optic nerve.
give more space for the blood to accommodate in the orbit to prevent pressure on the orbit.
Right.
These two things prevents the complications of orbital hematoma. You give more space for the blood to accommodate. Is that correct?
Right, sir.
इसमें डालना कैरोटिड, एक सेकेंड, सर्च में लिख कैरोटिड. Now, coming to the next step, we saw this was the prominence of the nasolacrimal duct. See this? If I,
Yes, sir, yes.
this is one of the common surgery we perform in our practice. Let me uncover this.
Endoscopic DCR.
Just to uncover the anatomy, how this duct is going. Can you see? I am uncovering this region. See this bone? Hello?
Yes, we can see. It's the hard bone.
Hard bone. Give me the
lacrimal
calcium.
bone, yes.
Now let me make a punch of it.
Philia copy.
We have seen the lower opening just now.
Yes.
Yes. That's the entire nasolacrimal duct you can see. See the nasolacrimal duct? That is the duct.
Yes.
This is the nasolacrimal duct. See this duct?
Yes, we can.
See the inside of the duct. See this?
Yes,
Yes,
we
sir.
can see.
Lower one, and how it opens we have seen in the inferior meatus where it opens. So this is the nasolacrimal duct. Our philosophy in DCR surgery is this duct can be easily identified in the lower part. Don't look for the sac in the upper part, which can make your life hard. See this?
Yes.
Once you have seen in the lower part, open up the sac. Follow it to open up the sac, and it becomes so easier and marsupialize.
Right.
Secondly, see this,
Yes.
keep going up until until you see the common canaliculus. This is another thing which you can take the help in your practice. If you see the common canalicular duct, if you go to that high, the chances of, even if your flap falls back, the chances of restenosis are very less.
Right.
See this?
Yes, sir. Perfect.
Here, this is the opening of the common canaliculus here. Give me, watch with no? See, this is the interior of the nasolacrimal duct.
Yes.
Here is the opening of the common canaliculus, somewhere here, this one. This should be thoroughly exposed and marsupialized like this. So it can never re-stenose. This marsupialization is essential to prevent re-stenosis. Okay? So that doesn't take long. Now coming to the Rajat's question about the infratemporal fossa first. Then we'll go to the,
Satish,
yes.
pre-lacrimal approach.
Hello, I can't hear you.
Pre-lacrimal approach.
Pre-lacrimal, yes, that is another important question. See, we do modified Dankers, medial maxillectomy, there are many approaches. But all those approaches go through the nasolacrimal system that you need to sacrifice. Though, if you cut sharp above, the epiphora doesn't happen. That point? Now, but those are the approaches where, those are so versatile. Those are so versatile, those approaches, that you can, if you remove the medial wall, if you do a modified Danker, you can follow the entire life. You can follow the entire life, the pathology if it is coming back. Suppose you have done a the maxillary sinus lateral wall lesion, and you have done a modified Dankers, you removed everything, you have a papilloma there, removed. Now with the 0 degree, once the medial wall is removed forever, you can follow in the OPD so that your radiology is not required. Pre-lacrimal approach is not suited for such lesion. Pre-lacrimal is what? Making
Sir,
a
but it is
window.
good for AC polyp if it is
Yes.
attaching to the interior
Any
wall.
benign pathology,
Yes.
any benign pathology which doesn't require a long-term, so stringent follow-up,
Yeah, exactly.
still you can do with it. You can use it as a port to look into the maxilla anteriorly.
Interior sinus, yes.
What's my point? Suppose you have an odontogenic cyst, which is situated anteriorly. You can't remove through the natural ostium effectively. What you can do? You come by the pre-lacrimal approach, that's making a window I am going to show you. So you have another port to deal with the maxillary sinus, anterior maxillary sinus pathology. Got my point?
Yes,
That
sir.
way, you open that space, deal with the pathology and reposit the flap and come back. You don't leave a space for the long-term follow-up. So pre-lacrimal approach spares the nasolacrimal system, but doesn't leave space for the long-term follow-up. But so it is used for the lesions which have least chances of recurrence. Got my point?
Sir, one question is there, sir. If a patient comes with misplaced dental implant inside the maxillary sinus, how will you take it out?
Pardon, can you repeat? Yeah, please.
Fine.
What was the question?
Please say the question.
Sir, the question is if a patient comes with dental implant inside the maxillary sinus,
do
how
a-
will you take it?
So-
Calvilloc approach
How
or
can we take it out?
Yes, Carnivore approach or the medial maxillary antrostomy approach.
And anything,
See,
whatever you're comfortable
foreign bodies exposed in the maxillary sinus
That will easily added.
naturally have to be removed.
You want to do endoscopic technique by that. If you don't want to do endoscopic technique.
So
Yeah.
actually, it's mainly the
Location.
pre-maxilla, premolars where it goes inside.
Wherever through the
Rarely-
wherever through the foreign body is going, you have to retrieve it back from there. Now coming to the pre-lacrimal approach.
Deal by wide MMA. You don't need to do anything.
Yeah. So
extra.
what I was talking about the pre-lacrimal approach. See this. You have seen the lacrimal system. Pre-lacrimal is make an incision over here. See like this. Raise a flap. Raise a
So
flap
at the anterior end of the inferior turbinate, you make an incision.
at the right at the this piriform aperture.
Yes.
Make an incision. Raise the flap right over till the nasolacrimal duct. And staying anterior to the nasolacrimal duct, make an opening by the drill.
Yes.
And go head on into the maxilla, inside the sinus. If your odontogenic says some biopsy you have to take, some, some polyp which you are not able to deal with, any other pathology.
So basically, it's neither a medial approach, neither an anterior approach. It's a junctional approach between anterior and medial wall.
The beauty is elevate the flap, open the maxillary sinus, deal with the
And
anterior
take the
sinus
sutures.
pathology, and reposit the flap and put a suture over here and come back. So it is a great approach for the limited lesion, but doesn't leave option for the follow-up. In modified Denker, you remove the entire lateral wall. Suppose you have a papilloma, whatever tumor. Now you have a 0 degree to follow up for life. So follow-up is one thing which has an advantage by the modified Denkers. Pre-lacrimal is a more conservative approach where you don't sacrifice the nasolacrimal system. You do your job, come back and reposit the flap. So you don't actually alter the normal anatomy. That's the difference. Okay? Now, coming to the Denkers. Now, we have already done the nasolacrimal duct work. So, I will show you the modified Denkers. You have seen many a times in the live surgical situation, nothing new. But still, quickly here, because I am going to the infratemporal fossa region very soon. See now what I am doing. In the live surgical situation, we do this with a cobblator. That is much easier.
Yes, sir.
So elevate this mucoperiosteum of this bone.
And identify the piriform puncture.
Yeah. And my anterior limit is this piriform aperture. See this bone?
Yes.
So this is my piriform aperture. See this?
Yes, sir.
If I go to the anterior side
Right.
in the subperiosteal plane, see this?
Yes, sir. Yes, sir.
I can remove along with this the anterolateral wall as well.
Right.
This is the most versatile. Long back, the Denker described this by the sublabial route. This is modified by the endoscopic route. See this?
Right. Right.
So देखो,
See, my lateral limit for this is the infraorbital neurovascular bundle.
Right.
That's the lateral limit in general. See this? You can elevate very well.
Sir, how are you taking control of the lateral tissue? I mean, it keeps falling.
So you see my assistant is retracted.
Yeah, right, right.
Now see, this is your infraorbital neurovascular
Yes.
bundle.
Yes, we can see that.
So
Perfect.
until then you can remove it completely without any fear.
Right,
But depending on the situation, how much you need it.
right.
See this? See, my assistant is retracted here,
Perfect, perfect.
and you can deal with this bone effectively.
Right.
Now, if I remove this bone, I will have head-on access to the maxillary
Posterior wall
sinus.
of the maxillary sinus.
Maxillary sinus and further beyond. That's the beauty.
Right.
During this process, you have to remove the inferior turbinate also, which is a separate bone. See this. This inferior turbinate is a separate bone. I fractured and I can remove it. See this? You have to cut the nasolacrimal duct flush with the orbital floor.
Yes.
So it doesn't overhang and lead to epiphora.
Right.
This is the most versatile, approach for the paramedian access to the skull base. I'll tell you in no time what area of the skull base you can easily explore. This is amazing. You're seen in the...
Sir, we will see the temporalis fascia from nose.
Yes.
And we will do it in penoplasty.
See this. I'm exposing this bone completely flush to the floor. See, once you are dealing with a deeper pathology and want to go by this approach, this bone has to be flush to the floor, otherwise it will hamper your instrumentation. This is important. Do this in beginning, spend 5 minutes and get a good uninterrupted access. Now,
so all of the inferior turbinate is gone.
Yeah. Inferior turbinate is gone. You have to remove the inferior turbinate and flush with the floor. See the floor.
Yes, perfect.
Remove everything. Now, lux. Now I have to remove this bone. I have many ways. I can use drill. I can use chisel hammer. Drill is
the puncture
drill
is
is
done.
Yeah, drill is the most precise way, most precise, most controlled way.
Right.
If you don't have a drill, you can use the chisel hammer.
Yeah.
One of the fastest way, though crude.
Chisel hammer is very easy.
But crude.
Yeah.
See now.
So you can, I think Medtronics is having their 15-degree drill. You can show that.
Yeah, I will show.
Yeah. So
see now what I am doing. Yeah. See quickly what I am doing. At our center, we do almost daily dankers. Everybody is used to this. And this is an amazing, versatile approach to the paramedian skull base.
Right.
In COVID times, you have seen in mucormycosis, this was as an essential to deal with the maxillary artery and lateral areas. Now, see the head-on access to the maxilla.
Yes.
And sir, it also make the maxilla accessible for post-operative surveillance.
Yeah.
That is important. That's what I said. The pre-lacrimal approach doesn't give post-operative surveillance opportunity. Got my point?
Right.
That's a sort of getting another port and come out. But this is the most versatile. See now, I am removing this medial wall. I am removing this mucosa as well. Yes.
So we can see the infraorbital nerve so well, sir.
Yeah.
Yes. See this
that will
very well.
Posterior wall is so clear. Posterior wall, I think the posterior wall is also thin, I think, sir.
Yeah. और देख ले clear now. This is the nerve.
Yeah.
See how it was going. Nerve and vessel together. That's the canal. Earlier, this used to be the limitation that beyond that you cannot go. Now we can transpose this nerve and go 360 degree beyond into the infratemporal fossa from here. We can remove the entire bone. See this? Beyond the nerve we can remove. I can transpose it and remove it safely.
Perfect.
Now, removing this mucosa, I'm just going quick to show you the critical areas. See this?
Yes, sir. Yes, sir. We can see.
I want to show as much as possible important thing in the given time. Now, see the maxillary sinus posterior wall.
Right.
This is your terminate, just to orient you. I can catch you there.
Sir, can you show the VDN also at this point of time?
Yeah, that's what I'm coming to. What
Yes.
Pachori boss had asked, I have to show.
Want to see every nerve, maxillary, median, optic, or
All the nerves, all the nerves we'll see.
Yeah, all the nerves you want to see, boss.
Now,
This
see
is
the
crista,
posterior
sir,
wall.
crista. Yes. We can see the crista.
Yeah, we can see Chris.
Yeah.
Yeah.
Now see, this is see, to understand this area, you have to understand one bone, very important bone. Can you see
Palatine.
this vertical bone? See this,
Yes.
let me elevate the palate. See this. See the floor of the palate?
Yes.
Yes, yes.
Floor of the palate is formed anteriorly by the maxilla.
Right.
And here posteriorly, this bone, it
Right.
has a horizontal part palatine bone and a vertical part palatine bone.
Right.
See this? Now this vertical palatine, as it goes up, divides into two processes.
Right.
Suction laga. See this.
Pterygospinoid and
पतला ले यार ये. नहीं बहुत मोटा है.
palatovaginal canal.
हाँ. Now, it divides into two processes. The one anteriorly going up, see this one is the orbital process. Let me break it. Yeah, this one is the orbital process. Can you see?
Right.
This one forming the part of the floor and the medial wall of the orbit. See this? And what is there behind the orbital process?
Spinopalatine.
Yes,
foramen.
that's why I showed you.
Artery.
There are two processes this palatine bone ends up. The anterior one is the orbital process and the posterior one is the sphenoidal process. And in between these, roofed by the sphenoid, is the foramen called spinopalatine foramen. See this, after removing the orbital process, what you see the spinopalatine artery.
Sir, can you just point out the crista, sir, at this crista? the
Crista is
lower
removed
part?
as a part of the orbital process.
Yeah.
Ah, yeah, yeah,
That's what.
yeah, yeah. This
I have
crista-
removed, man.
Right.
Now behind this is sphenoidal process. See, this sphenoidal process contains nerves. What you are looking for. This sphenoidal process contains nerves. The most superficial here is the palatovaginal canal. I will show you first video and that day. So first of all, what we have found, see, once you open the posterior wall of the maxilla, see the first structure you come is the periosteum behind. Can you see?
Right.
Now the orientation of structures in this region is classic. See, I am removing this bone quickly. I am going
Artery
quick
veins
to
and nerves.
utilize the time maximum for other important things. Yeah. See this. That's the pterygopalatine fossa.
Yes, sir, yes.
I am opening further.
There is no upcut. I mean,
So
Pardon?
you can use carisons.
Yeah, we can use.
I think the wall is quite thin, so.
Yeah, that's why. And I want to show you some structures there.
Right.
Now, see, behind the periosteum is some fat, and see some fat in between,
Right.
and the anterior arcade network of vessels.
Vessels.
All these are the
Branch of maxillary artery.
related to the internal maxillary. See this. See gently, if I open up,
At
this internal axillary network,
Yeah,
internal
we
maxillary
can see that.
network,
We-
amazing.
IMAX is there.
See such a tortuous course of this vessel itself, number one, which continues as sphenopalatine artery.
Palatine and
See the tortuous course and the fat.
Right.
Now, it gives branches everywhere. See this. This was the V2.
V2, yes.
It gives a branch along with
Orbital
that. Can you see
continuous
that?
V2.
Can you see the branch?
Yes, sir.
Yeah.
Intraorbital
Given off
nerve.
here along the V2. The,
Yes.
okay? This artery. It gives a branch behind, see this? Posterior superior alveolar artery. Going below. See this? That's the artery going below.
Yes, yes.
It gives branch
Sir, at
above.
Sir, at this point of time, I would like to ask a small question.
Yeah, please.
Supposingly we are doing a JNA and it is grade 1, and we did a modified Denker, and now we are at posterior of the maxilla, and we want to go to the maxillary artery. So what should be the level above the floor where we should try and find maxillary artery?
Yes, that's a great question. And you can be 100% perfect if you get a CT angiogram done in the DICOM and measure the distance of the horizontal course of the internal maxillary above the level of the hard palate.
Right.
You can get millimeter accurate.
Okay. Okay.
That's what we do always. That's why I always mention to get a CT angiogram done before JNA.
Okay.
It not only gives you information about the vessel supplying, the most useful, and you have to run yourself and see how the vessels are entering into the tumor,
Right.
how the vessels are displaced by the tumor.
Right.
Many a time we have seen the vessel entering into the tumor from front, from behind, from laterally, different ways. If the tumor has displaced the vessel, it is not going to be, found easily. And many a times, even I got the call, sir, we are doing JNA, following you, but I am not able to identify the vessel.
Right.
So always get a CT angiogram done. That will tell you on DICOM exactly how superior the vessel is from the palate. Rajat, I can tell you after this session, if you give 5 minutes, I will run a CT angiogram and show everyone how to see that.
Yes. Please, sir.
Sure. Now, that is important. That will make your life so easy, it will make you more confident.
Right.
Now the vessels, see this going medially. Everywhere see this pterygopalatine fossa is like a crossroad. It's a very narrow space. This is the medially and laterally the limit is this pterygoid process here.
Right.
In between this is pterygopalatine fossa. And this laterally, all this is infratemporal fossa.
Yes, sir.
Now, this pterygopalatine fossa is communicated all around. It's like a crossroads everywhere. For example, it is communicated with the palate through the greater palatine canal. Can you see?
Yes.
And see what is going through. From this, the greater palatine artery, and from this, the greater palatine nerve. See this? Running through this canal, greater palatine, to supply the palate. Can you see?
Yes, sir. Yes.
At the medial edge. And I tell you, this is one of our most preferred flap nowadays in situations when we don't get a Haddad flap for reconstruction. Simple. You can raise very well. Very, very simple. No technical challenge. The palatine flap. This is so versatile. See, if I show you from below, this is hard palate. You must have seen the plastic surgeon doing a palatoplasty.
Right.
make an incision along the alveolar line all around, alveolar ridge. See this?
Okay.
And raise this entire thing behind over
Right.
the hard palate.
Right.
Okay? Cut from the opposite side based on one side, greater palatine.
Right.
Okay? Now, this is a huge flap. And it has a big pedicle. Now, how to get to the skull base? See, this is greater palatine artery.
Right.
I will make 1 centimeter entry into the, I elevate the mucosa, make 1 centimeter entry into the palate,
Okay.
hard palate, and get the flap inside into the nose.
Okay. Okay.
And once the flap is in, I will deposit my mucosa back to prevent palatal perforation.
Okay.
Like this, okay? Now you will get the flap inside. This flap is based on this pedicle.
Okay.
Now if you want to take to the skull base, see this is long, long pedicle. You can take this, if you want to go further, you can take the pedicle up to here and your skull base is there. So
Right.
that's an amazing flap, very simple, absolutely free of complications, believe me. Because the palatal mucosa will regenerate, this palatal perforation won't happen, and this is a versatile flap. There's a long pedicle till here, here to here. Flap, you can take the flap to the skull base so easily, and a thick periosteal flap that is.
Yes. Yes. Perfect.
So in case you don't have any other flap available, you can use that easily. And it doesn't take time, 10 minutes. Okay? So now this is one vessel, greater palatine neurovascular bundle. Okay?
Right.
You have seen all orchid of vessels now. Above this gives the zygomatic vessel. Now behind, now see the most important thing. Behind is the pterygoid process. See here?
Yes.
That's the palatine bone. Here is the pterygoid bone above.
Right.
Now this vessel and this nerve give lot of branches passing through the pterygoid bone, through
Pterygopalatine.
various foramina.
Those are.
Yes.
Now see where this going, one by one, where this nerve is going to. See this. This V2 is coming out of where?
Median. Median.
Foramen rotundum.
Yeah, this V2 is coming out of foramen rotundum. Let me show you. That's the foramen rotundum where the V2 is coming out.
Yes.
See, this is, let me clear it to show you very, very clear.
Boss, what is maxillary strut?
Yeah,
here?
that's what I'm coming to. Good point. See, can you see where this nerve is coming out of? This one.
Yes.
This is foramen rotundum. कुछ गौर से देना. Let me clear it off. I will show you all the foramens in this pterygoids. Pterygoid bone is the source of spread of infection to different areas. Lots of cranial nerves comes out of the foramens in the pterygoid bone. V2 is one of them and can be a source of perineural invasion of tumors going into the brain. See, these are posterior nasal nerves. I'll come to it. Now, see this. This is your V2.
Yes.
This foramen here.
Foramen rotundum.
Yeah.
Yeah, this is foramen rotundum. See that?
So,
It is facing, foramen rotundum is always facing forwards, not downwards.
right.
Yes. Great point.
Yes.
Section kar. Yes. So this is foramen rotundum. Okay?
Right.
Now, this is pterygoid bone. foramen rotundum is superolateral. See now, let me elevate the mucosa to show you some more foramens. Yeah, periosteum. This is the periosteum I am elevating. See this periosteum?
Yes, yes.
Can you see the foramen there?
Yes,
median
yes.
canal.
Median canal.
Median canal. See, this is,
So more medially we have the median
yeah,
and
this is
laterally we
foramen
have-
rotundum. Infero-medial is the median canal. See this?
Right, right, right.
And contains the median artery, which could be a branch of maxillary from this side, internal maxillary, or could be a branch
Or
from the
from
internal
ICL,
carotid
yes.
behind.
Can be ice from ICL.
Now see the median now. See this? Now
Yes.
another nerve going medial to the median now. Can you see that?
Palatovaginal.
Palatovaginal canal. Now see the question from Pachori boss about the median nerectomy, which is almost obsolete for us now. I had done earlier, but now with the understanding of the posterior nasal nerves, we have given up. We do posterior nasal nerectomy in as an adjuvant procedure in all patients while doing sinus
Sorry,
surgery,
sir, you are not
septoplasty.
here. You are absent here.
Hmm?
He is on the way. He is on the way. I think about to reach.
अच्छा, तो दूर से मिसाइल फेंक रहे थे. See now, this is foramen rotundum. Can you see?
Right.
Yes, yes.
And
very
this
well.
is the median canal. You can see.
Yes, yes.
And medially, that's very important. That's a sensory nerve, thick sensory nerve. See,
Is
this
the posterior
passes
nasal
underneath the mucosa. This passes between the sphenoid body above and the vaginal process of the palatine bone below. This is palatine bone. That's the vaginal process of this bone. See this in between. This
Right.
is palatovaginal canal. This is a sensory nerve supplying the nasopharynx and the part of the sphenoid, inferior part of the body. See this? So,
Right.
1, 2, 3. Now, what is this nerve? This is the nerve which is, first of all, where is the pterygopalatine ganglion? See this. Ganglion is suspended on this nerve, this thing, on this V2. V2 suspends the pterygopalatine ganglion, and from ganglion, lot of nerves arise. And one of them, see the medially bunch of nerve go. Can you see the bunch of nerves? Thin filaments. Can you see this?
Yes.
This is the ganglion giving thin filaments of nerve. See, there's a lot of nerves, fine nerves. They pass through the pterygoid bone here to come in the nasal cavity here. These are, see what happens. If we look at the anatomy, how the median nerve is formed? Median nerve is formed by the facial nerve. The greater superficial petrosal nerve joins the deep petrosal nerve in the foramen lacerum to form the median nerve and then comes forward. And then these fibers are delivered in the pterygopalatine ganglion. See this median nerve?
Yes.
Delivered in the pterygopalatine fossa ganglion here.
Yes.
Right.
Sir,
And
can you
from
show
here-
the lateral recess just for the juniors that where exactly is the lateral recess?
Yeah, I will show.
Yes.
As I go behind. So now from the pterygopalatine ganglion here, some fibers medially emerge. See this? These contents, see this. Greater superficial palatine nerves contains the secretomotor fibers for the nasal and palatine glands. That's a branch of facial nerve. Joins the deep petrosal in the foramen lacerum to form the median. And those secretomotor fibers, are relayed in the pterygopalatine ganglion. Can you see?
Yes,
And
right.
from there, those secretomotor fibers are selectively taken by these nerve filaments across the palatine bone. Some perforations in the palatine bone here. See, lots of minor perforations. Can
Yes,
you
yes,
see?
yes.
While elevating the
Will be
flap, I have
formed
seen
like
it. Can you
areas.
see minor perforations?
Yes, cribriform like
So
area.
those, yes, so those fibers from this, this pterygopalatine ganglion pass through posterior nasal nerve fibers.
Nerectomy, yes.
And they are relayed in this region between the middle and the inferior turbinate.
The net.
Between the middle and the inferior turbinate in this region. See this?
Right.
And from there, they are related to the inferior turbinate, they are related to the palatine glands everywhere. Posterior nasal nerectomy contains those fibers which are secretomotor carried in the Vedian nerve. Vedian nerve additionally carries fibers for the eye,
Yes.
you know, for the tears. If you cut the Vedian nerve, can lead to a dry eye.
Dryness of eye.
If you selectively transect the posterior nasal nerve, will selectively serve your purpose of video nerectomy.
Yeah.
So nowadays what we do, posterior nasal nerectomy. How you can simply do it? Just elevate the periosteum above this perpendicular plate of the palatine bone. You will see the nerve fibers. You have to sever them. Now how you can do? Don't even look at that. Come with a cobbleator between the middle turbinate end and the inferior turbinate end. See here in between. And cobblate this 1 square inch area. That's it. Automatically all nerve fibers are going to be damaged. As simple as that. So you don't have to look at anything. Take a cobbleator and cobblate in 10 seconds your posterior nasal nerectomy done. As simple as that. That you can use as an adjuvant procedure. Adjuvant procedure to all sinus surgery cases who are severely allergic, to all septoplasty patients who are severely allergic. So it's an adjuvant procedure, not as a sole procedure to treat allergy or anything. So there is no harm in doing that as an adjuvant procedure. I hope it is understood well.
Yes,
Hello?
sir. Clinic all clear.
Clear. So now, the
Sir,
network.
just so the lateral recess, sir.
I don't. Yeah, I am coming to Amit. Now see this nerve. This nerve gives a branch above. See this. That's a zygomatic branch. See this. This zygomatic nerve forms the zygomatic or temporal branches. See here in the depth. This is zygomatic nerve. This joins the lacrimal nerve and useful for the lacrimation. See this?
Okay, sir.
This contains the lacrimal fibers of the Vedian nerve.
Okay.
Got my point? That we are sparing by preventing the Vedian nerectomy. Can you see this very well?
But sir, when we do JNA,
Yeah.
so except this except this foramen rotundum and infraorbital nerve, rest of the things are destroyed. So, but
Most of the time, it becomes non-functional by a big tumor.
Yes, oh, exactly. Okay.
Yeah.
Because these patients never complain of dryness of
Yeah,
eye and other
it
things.
can. It's not in 100% patients.
Okay.
It can, because there are other alternative routes of, lacrimation through the V1.
Okay.
Through the V1, ophthalmic nerve.
Okay, right.
I will show you ophthalmic nerve soon and how it works and what all it does.
This is the pterygoid wedge area, sir, and the pterygoid.
Now, can you see the pterygoid process now?
Yes.
I have cut the medial fibers of the nerve and vessel. This is the foramen rotundum,
V2,
and
yes.
this is the V2. I hope it is very clear to everyone now.
Yes.
Now,
Absolutely clear.
feel free
And
to
we can
interrupt
see
me,
that
please.
one is into the medial pterygoid in the line, and the other is in the line of lateral pterygoid.
So this is pterygoid process now. First of all, everybody, make very, very clear about the anatomy. If you have any doubts, feel free to interrupt. This is pterygoid process with the medial and lateral plates. Okay? See this? And this is the region of the pterygopalatine fossa. Okay? Now here was the posterior wall of the maxilla. Between the pterygoid and the maxilla, this was the pterygomaxillary fissure. Okay?
Yes, sir, yes.
Through which all these things are going in the infratemporal fossa. So this was the pterygomaxillary fissure. If I replace my maxillary wall here, between the pterygoid and the maxilla was the pterygomaxillary fissure, through which the pterygopalatine fossa was communicating to the infratemporal fossa. Is that clear? So all these
Sir,
structures.
can you just point out what is the difference between the pterygoid process and pterygoid wedge?
Pterygoid wedge is the area which is the inferior part of the anterior surface of the pterygoid process known as pterygoid wedge. This area is often involved with abnormal vascular venous plexuses, and it is supposed to be giving origin to the JNAs as well.
DNA.
So this is the anterior most edge of the pterygoid process. Now, fossa is different. Pterygoid fossa is between the two plates. I will show you. Pterygoid fossa is different. Okay? Now, this is lateral pterygoid plate, and lateral to that is all infratemporal fossa. Can you see?
Yes, sir.
Infratemporal
Because
fossa
lateral
means.
to that is the inferior orbital nerve.
Pardon?
Sorry. Lateral to that is the foramen rotundum V2, infraorbital nerve.
Yeah, this is V2 only. This continues as infraorbital now.
Yes, sir, but these come in the line of lateral pterygoid plate. That is what I'm saying, sir.
See, this is above. This is above. This V2 continues above like this in the floor of the orbit. Floor of the orbit, it continues and come out as infraorbital now. Come out on the anterior surface of the maxilla. Now, coming to the infratemporal fossa, as the name implies, why infratemporal fossa? Because it is below the temporal lobe. Above is the temporal lobe of the brain, and below the temporal lobe is the infratemporal fossa. So where is the temporal lobe for you? Where is the temporal lobe? See.
So it is behind this this whole vasculature, and the fat is to be removed.
See, let me tell you one thing, just to, so that you'll never forget.
Yeah.
This V2
So this is
runs, see this, V2
Yes.
runs through the floor of the temporal fossa. Temporal fossa means temporal lobe.
Lobe.
This V2 runs through the floor. Okay? And this is infratemporal. So let me first show you the temporal fossa so that you can understand the infratemporal better.
So the
Okay? Till there.
greater wing of the sphenoid forms the part
Yes.
of the greater wing of the sphenoid.
Yeah, that forms the roof.
Of the infratemporal
That's,
fossa.
yes. So, your point is correct. So, what I said, ki above is the temporal lobe.
Yes.
So, floor of the temporal lobe is formed by greater wing of the sphenoid.
Greater wing of.
And below the temporal lobe here is the infratemporal fossa.
Yes.
So, roof of the infratemporal fossa is formed by greater wing of the sphenoid.
Greater wing of sphenoid.
Clearoid? Clear? Now, give me the drill. Let me show you where the temporal lobe is. So, this approach, see, you do the dankers like this, go above, find the V2, go above the V2, you are right in the temporal lobe of the brain to remove the tumors from there. What a fantastic head-on approach. In 20 minutes, you can reach the temporal lobe of the brain, which no other approach can provide. Okay. See now what I am doing. काम ही हो गया तो क्या लग रहा है कर सक्शन कर ऊपर से ऊपर yeah, see this?
Yes.
कर yes.
So we
See
are
where I am.
Temporal lobe
यार
now.
ध्यान लगाना
cranial.
सेक्शन वहाँ एक छेद पे लगाना कदा है यार वहाँ लगाओ अरे यहाँ लगा गुरु छोड़ see this what you see there what I have drilled that is the temporal lobe of the brain can you see
Yes.
hello
Yes, we can see, boss.
because it is a cadaver 1.5 and old so it is autolyzed.
Yeah. So we have seen in mucormycosis cases, whole of this bone becoming black due
Yes,
to mucor.
very often involved.
In those era, and we used to drill. I think many times I have drilled. I've never removed this bone, a normal bone, but Yes, diseased bone, especially mucormycosis, we have removed.
Yes. See now what I'm trying to say.
This bone is eroded in JNA when they have
Yes, yes,
extra.
very commonly. Now see, where I am? In the temporal lobe of the
Into the
brain.
temporal
See,
lobe.
in the temporal fossa of the brain where the temporal lobe is. Can you see the temporal lobe?
Yes, yes, yes.
Very clear?
Yes, sir.
That's why this is infratemporal fossa.
Yes.
The in-between bone is the greater wing of sphenoid.
Yes.
See, all the nerves, cranial nerves in this region come out of the brain through foramina in the sphenoid bone. Sphenoid bone means maybe through the greater wing, maybe through the pterygoid bone. All the neurovascular structure traverse through the sphenoid bone components. See this?
Satish boss, what is Vidian V2 corridor? What does that signify?
Corridor means it is a space between these two through which you can access the lateral recess of the sphenoid. I will show what Amit was asking.
Satish sir,
Yeah.
can you show me, can you please show the relation between greater wing of sphenoid and orbit and temporal lobe?
100%. That's what I am coming to. At the end, I am coming to this 1 square inch area. So I told you. This 1 square inch area is the one most crucial for the endoscopic surgeon. Means, see here, this is carotid artery,
Yes, sir.
sella,
Yes, sir.
optic nerve. Lateral to the carotid is what? Cavernous sinus containing cranial nerves into the coming to the orbital fissure, and immediately lateral to the cavernous the cranial nerve is the temporal lobe of the brain. So all these structures together, you know, is the region where many tumors enter into and
Sir,
make the life difficult. See now, this is our V2. This is our temporal lobe of the brain. Can you see?
Yes, sir. Sir,
And
show
where the
the
V2
orbit
runs
also.
into, where the V2 runs through? Through the floor of the temporal lobe.
Yes, sir.
See, this is the floor. See this?
Yes, sir.
I hope it is very clear.
Yes.
Sir, limitation of the orbit.
I am coming to. See that? That is the V2 where it runs through the floor of the orbit, floor of the temporal fossa. Hata de. Okay? And this is infratemporal fossa. Just to orient yourself, this I explained like this. I hope it is very clear. Now,
Clear, absolutely.
this is, as I mentioned, is the head-on approach to the temporal lesions. See this? Tumor from anywhere going to the temporal lobe can be removed from here. JNAs are very often we remove. Schwannomas of the temporal lobe, the schwannomas of the, trigeminal nerve can prolapse from here down. We remove from here. Meningoencephalocele from here come down and we can remove from here. So this is a versatile approach. See head-ons, go do modified dankers, go to remove the posterior wall, find the V2 and then open up the temporal area. And you can remove whatever you want to and close the defect with the Haddad. Okay?
Right.
Is that clear?
Yes. So
It's clear, sir.
yeah. But in those cases, we have to take Haddad from the opposite side.
Yes, because the artery is injured. Now,
Yes.
to answer your question, many a times, when we don't have a malignant pathology, and still we can preserve the artery. What we do, we raise the Haddad, not only the septal branch, but we elevate it all the way along with the maxillary artery till here. Got my point? We elevate the maxillary artery all the way rather than damaging it and use the same maxillary for the flap. Rather than based on the nasoseptal branch here, we can make the Haddad elevate and elongate it right till the, based on the maxillary artery directly. What's my point?
Yes, sir.
If your pathology doesn't dictate to sacrifice the maxillary, you can still use the same side even after this dissection for the Haddad. Okay? Now, this is the V2. So this is the approach to the temporal lobe, very, very clear. Now coming to the infratemporal fossa, this Rajat was asking, in the infratemporal fossa, see this is lateral pterygoid plate. This muscle which is inserted on the lateral pterygoid plate, lateral wall is what? See this? Which muscle is this? Lateral pterygoid. See this? Lateral pterygoids have two heads. See? Insert on the lateral pterygoid plate. See the lateral pterygoid plate. This is all lateral pterygoid muscle. All lateral pterygoid muscle. And if you go lateral, if you go lateral to it, you'll see the vertical temporalis muscle. See all this fat in the pterygobelt and fossa. I have to remove this bone and you will find the temporalis muscle and then the mandible laterally. That's the temporalis muscle. So this all pterygobelt, the infratemporal fossa is a area which contains muscles. This lateral pterygoid, Carrison. And below down is the medial pterygoid. Medial pterygoid is below. Medial pterygoid is insert
Sir,
something
sometime
on the other
Jain
side of the
go-
lateral plate and going to the mandible edge below. Yes, what?
Sir, sometimes the JNA goes to the parapharyngeal space from here.
Yes.
So, which pathway does it take, sir?
Yes, by destroying the pterygoid bone.
Destroying through the pterygoid bone?
Yes, yes, always.
Okay. And does it follow
You have
the lateral pterygoid muscle?
Yeah, that is pushed.
Okay.
Pushed.
So in between the lateral pterygoid and the pterygoid bone, it goes inside.
Yeah, and posteriorly it is pushing the medial pterygoid. Medial pterygoid muscle is one which is something which separates from the internal carotid artery behind. That is anterior to the carotid artery. So any tumor going from anterior to posterior, the medial pterygoid comes in the way to protect the carotid.
Okay.
So medial pterygoid is a useful muscle to protect the patients and the surgeon from the carotid artery. We'll show, if time permits, the carotid course. See now. Now. See, I am more and more opening the infratemporal fossa. It's a huge space. See this? Containing muscles, neurovascular bundles, all this. Now the most important structure I intend to see here if I go behind. See, you have seen V2. See this?
Yes, sir.
V2 is given off by the trigeminal ganglion behind. It gives three branches. V2 horizontal, V1
sir.
up in the inferior orbital fissure, superior orbital fissure,
Yes,
and
sir.
V3 behind in the infratemporal fossa.
Yes, sir. Yes, sir.
So where is the V3? Lavai.
Foramen ovale.
Yes, that is the foramen ovale I am looking at behind the pterygoid process. With the divider there, थोड़ा खाली करो. See, I will show you V3 and V3 will divide into three branches. Auriculotemporal horizontal, alveolar nerve, lingual nerve, and here in the infratemporal fossa the lingual nerve is joined by the chorda tympani nerve. I am just debulking to show you because let me show you some, just to show you anatomy. Yes, there's something. So I will show you V3 and how useful the V3 as a landmark for the carotid artery behind, parapharyngeal carotid artery. I'll show you all possible good landmarks for the parapharyngeal. इधर से डाल. डाल तैयार है. खोल यार, खोल एक बार, खोल. खोल I am taking these soft tissues to show you something important behind. V3 comes out of the foramen ovale from the posterior most part of the pterygoid. So all three branches diverge from each other. V1 going up, V2 going horizontal and V3 going behind. क्यों खराब कर रहा है? On V3 again, say this. This is the temporal floor we have seen. It comes out of the temporal floor vertically down like a leg. Laterally, temporally. Section. Can you see the nerve? ब्लीडिंग बहुत हो रही है, जमा हुआ. आजा आजा. Yes, open. आँखा खोल. Hello. Here comes the V3. Hello.
Yes, sir. Yes, sir. We are with you.
This is the V3 which comes out. This V3 comes out from here. Yeah, section. See, collected hematoma in the muscles. Not able to. Yes. Once you see the V3, your carotid artery parapharyngeal is 4 to 5 millimeters behind. That's a great landmark. इसको पूरा हटा. Section, my dear. Section. Yes. So these three branches diverge from each other from the ganglion. I'll remove this part of the pterygoid so this doesn't come in the way. To show you all three nerves diverging from each other. That's the nerve here. That's the V3. Can you see? Hello?
Yes, sir. Yes, sir.
V3 here and one of its branch there. Yeah. So let me drill it properly to show you. So now this is V2. So now let me uncover. See, I am removing this floor of the temporal fossa. This floor of the temporal fossa contains so many nerves. And because of that, so many triangles have been described in this region. Yeah, see the temporal lobe. Bleeding. My God. 2 मिनट इसको पैक करेगा. रुकेगा ही नहीं. पैक कर for a while. Just pack for a while and come back. चेक कर रहे सोख लेगा ये ड्राई ड्राई दे ड्राई ड्राई टू सोक द ब्लड दे 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 just so this
Sir,
is
can you-
in the infratemporal fossa. I am in the deep infratemporal fossa.
Sir,
Sir, can you please show us the course of carotid?
yeah.
Yeah, that's what I am coming to.
Full course of carotid, sir.
Yeah. Now, I am coming to just leaving a. I will drill that bone.
So
Now,
15
this
more
is the-
minutes, sir.
15 minutes.
Yes, sir.
Oh. Okay. See, this is the median nerve. This median nerve runs in the floor of the sphenoid. It is
So
formed.
everyone stay back because we'll be having a hands-on navigation for everyone.
This was our V2. Above the V2, this is a thick bone. See this bone, let me separate. Can you see this bone? See this?
Yes,
This
sir.
bone above the V2 is the maxillary strut. This separates the V2 from the, this is superior orbital fissure. See this?
Yes, sir. Yes, sir.
If I remove this bone, medial wall, see this. Superior orbital fissure is what? See this superior orbital fissure is the continuation of cavernous sinus.
Yes, sir.
Now above this maxillary strut is the superior orbital fissure and it contains in continuity all the structures coming out of the cavernous sinus.
Awareness sinus.
So now,
Right.
carry some fast. Let me show you the sella cavernous sinus and relationship in the given time. Just a minute.
Sella.
Yeah, sella. I am opening the sella. Medially, I am opening the sella. See this?
Right.
Now. See, this is the sella here.
Yes, sir.
This is the carotid artery there.
Yes, sir.
सब कुछ चल रहा है.
This carotid artery and sella, this sella is attached to the cavernous sinus wall through these dentate
Sir,
fibers.
for the sake of the juniors, can you show us the lateral OCR and medial OCR?
Yeah, we are opened up. We are already shown. This is the lateral OCR.
Yes, sir.
वो रहा MOC here ऊपर.
Yeah. See, this is the pituitary gland,
Right.
Yes, sir.
and this is the carotid artery laterally. You can see. See the pituitary gland. Pituitary gland. This is the carotid artery. See this?
Yes, sir.
This carotid is taking a bend to go up. See this?
Right.
This is coming from here. See this?
Yes, full bend.
Horizontal carotid becoming anterior bend.
Awareness.
Right.
This is the clinoid segment and going subarachnoid where it is giving ophthalmic artery.
Right.
And this is the optic chiasma.
Yes, sir.
Right.
Above that is the anterior circulation, cerebral artery complex.
Right.
See this?
Cerebral. Yes, sir.
So this carotid is going subarachnoid from there. Now see the space. This is the horizontal carotid, anterior band and the clinoidal segment. Above the horizontal carotid is a good potential space. Can you see?
Right.
Yes, sir.
Here. And this space is where the pituitary tumor often invades the cavernous sinus easily.
Right.
See, this is the potential space. See this superior space.
Yes, sir.
Now this carotid artery, if I mobilize it laterally, see this?
So cavernous sinus nerves will be seen.
Now, if I mobilize it, the lateral wall of the cavernous is coming in view. Can you see?
Yes, you can
Yes,
see
sir.
the nerve. Six
Yes.
nerves.
So all these nerves which are coming from behind through the cavernous sinus are continuing anteriorly into the superior orbital fissure. See this?
Yes.
Right.
All the nerves. So superior orbital fissure is the anterior extension of cavernous sinus. Can you see very clear?
Yes, sir. Yes, sir. We can see.
Now see section. This cavernous sinus, the medial wall is formed by the carotid artery here. See the cavernous nerves in the lateral wall. See this?
Perfect.
Section there. I had shown you the temporal lobe earlier. This is
Right.
temporal lobe. बंद हो गया. See, this temporal lobe forms the lateral wall of the cavernous sinus.
Yes, sir.
This temporal lobe,
Right.
these are the cavernous nerves. Can you see one by one?
Right.
Yes, sir.
The most superior, yes. This is third nerve.
Right. Sir.
Yes, sir.
Behind and below the slender one. Yeah, that is the fourth nerve.
Right.
Below are two nerves. See this?
Yes, sir.
The medial one, which is coming right through the blood, is the abducent. And lateral one is the V1.
V1.
So four nerves.
You're bleeding out your temporal lobe, sir.
See all the nerves. And what is there lateral to the cavernous? Again. See, if I go through this, where I will go? See, now open up. Temporal lobe again. Can you see? Suction kar.
Right. Right.
What I wanted to
Can you show the Dorales canal?
Dorelose canal is a venous canal.
Yeah.
It is not here.
Sixth nerve
Yeah, yeah.
at the clivus and that.
See now, this is the temporal lobe again. Can you see?
Yes,
Right.
yes,
Right.
yes.
Right.
So this temporal lobe, what I wanted to see, this 1 square inch area. In this region are all the tigers. Sella, optic nerve, carotid, cavernous sinus, and the temporal lobe laterally. ये temporal lobe laterally.
Yes, yes.
Perfect.
So
I think
this
we
orbital
can call it
apex.
a day, sir.
Pardon?
Should we call it a day, sir?
Yeah. So I will show you one CT angiogram.
Yes.
What Rajat was asking, and then we'll call it a day. See, got my point?
Yes.
All
yes.
these nerves coming from here. Now, what is there behind? See, this behind the carotid if I elevate. This is V1 coming. Can you see?
अच्छा. पढ़ा दिखा देता.
This is V1 coming. They are going
Sir,
to be the
sorry, sir,
trigeminal
demand है.
ganglion
हडार
behind.
दिखा दीजिए.
Trigeminal ganglion behind.
सर हडार दिखा दीजिए. हडार पचौरी सर को देखना है.
Okay, 1 minute. Hadad is, yeah, must, everybody must know.
Because Hadad is needed for everyone.
Yes. See, Hadad is based on this vessel, which is the vessel run on the anterior wall of the sphenoid. See this? This vessel, the branch of sphenopalatine. See this? This
Right.
vessel. Now, Hadad is ipsilateral. You can take up the entire mucoperiosteum of the septum, preserving the olfactory region.
Right.
You can reconstruct defects in centimeters. Now, according to the need, you can tailor it.
Right.
I can, if want a long one, I can bring even to the vestibular skin till there.
Right.
If I want a bigger one, I can take the floor skin also along.
Okay.
If I want a double one, I can raise from both sides. Janus flap. Got my point? So, variety of Hadads can be elevated. The basic one, make an incision first, the inferior one, just above the choana.
Right.
Like this. Just above the choana, come anteriorly, not on the soft palate, come anteriorly here. Now, if you want the palatal mucosa, it's up to you, depending upon the otherwise along the floor of the nose anteriorly. Okay? Similarly, this incision above at the level of the ostium, so you don't injure the pedicle. Come horizontally for a while, for a centimeter or so. See where the middle turbinate comes. See this? And then you can rise up. This way you preserve the olfactory mucosa. Okay?
Navigation.
Hello?
Yes, sir. Yes, sir.
You can rise up anterior to the turbinate. Okay?
Yes.
And then you can go along the roof. High up along the roof, wherever big you want to. Anteriorly up to you, I can come more anteriorly like this, and join this, the inferior incision to it, to make it a complete one, and raise like you raise the septoplasty flap. See this? This entire flap can be raised with this incision marking.
Yes, sir. Yes, sir.
Yeah, so anteriorly up to you, you can just raise like you raise the septal perichondrial flap. See this?
अभी 10 मिनट बाद जाना सर, बैठ जाओ.
See this?
हैं?
See this like this?
नहीं सर, कहीं बुला रहे हैं.
No time, you can raise
अरे यहाँ पे navigation वाला होगा.
the dimension, you can increase according to the need. You can raise this entire ipsilateral mucoperiosteum. See this? And the pedicle is there. See this? This is my pedicle. This is my pedicle. Now I can cut from below here, and this entire flap can be raised. See my pedicle.
Yes, sir. Yes, sir.
Now this entire flap has been raised, and you can apply wherever you want to. See this flap? See this?
SP तो सारा तुम कब का
Use.
maxillary artery खोल डाली सर ने.
See this
Just
use.
flap it.
Use flap can be applied wherever you want to.
Sir, one person is asking that where to clip SPA. Please show SPA again.
SPA we have seen. Here I have cut. SPA was here. See this? So if you really want to clip SPA for epistaxis, go in the medial part of the pterygobeltine fossa and clip there rather than clipping here.
Just do a SPA ligation on the opposite side.
Opposite side.
Yes.
Okay. See this. Is it DNS on this side? See now. Bundle.
Bleeding is happening.
No. See what I am elevating.
So he has identified the maxillary sinus C, and that is the crista.
Yeah.
And just behind the crista, he'll elevate.
Yes.
Can you see?
Yeah, I have reached. See the vessel?
That is the vessel.
In no time I have reached the vessel. Look जाओ. See the vessel, can you see?
Yes, sir. Yes, sir.
You want to show on the screen? We'll do that after this. So.
Now see the vessel coming from the pterygobeltine fossa. Can you see? My submission is always ligate this vessel.
So we'll be
Don't ligate this vessel in the nasal cavity.
SP ligation, don't worry, just after this.
See, don't ligate this vessel in the nasal cavity distally, because it may give off other branches before that, and that may be inadequate.
Sir,
So
I think
ligate, identify the vessel following the medial part of the pterygobeltine fossa like this,
Right.
and ligate little laterally.
Perfect.
So the main trunk can be ligated. See the main trunk here, and see the two branches here. If you ligate in the nasal cavity, one of the branch may be missed.
Right.
So ligate the main trunk. See the example here. Ligate the main trunk here. See the two branches. See this.
Yes.
If I ligate in the nasal cavity, the other branch would be missed, and my procedure will be ineffective. So always ligate in the medial part of the pterygobeltine fossa there. Yes.
Perfect. So we call it a day, sir?
Yeah. So I'll show you the CT angiogram.
Yeah.
just quickly,
Yes.
and course of the carotid artery. One thing I wanted to show. इसको
Please,
कनेक्ट करना जरा उधर से कैसे होगा? लैपटॉप को कनेक्ट करना. इसमें से मेरा माउस दे देना.
So we are done with the cadaveric dissection. Sir will be showing a CT angio of any JNA patient. Then one small video of SPL ligation, and we'll have a hands-on of navigation.
कनेक्ट किया क्या लैपटॉप? क्या हुआ?
Yeah, audio will please connect the laptop. Sir, आप यहाँ आ जाओ, यहाँ पे दिखा देना.
नहीं ठीक है सर, कनेक्टेड है.
सर आ जाइए, यहीं आ जाइए सर. सतीश सर.
हाँ
सतीश सर.
हाँ.
ऑडी आ जाइए सर.
पढ़न?
ऑडिटोरियम आ जाइए सर. यहाँ पे दिखा दीजिएगा आराम से.
That's 2 minutes.
Okay, fine.
I think कर रहा है कनेक्ट कर रहा है. Just a minute.
Okay.
क्या हुआ डियर? So what I want to show is
CT ambulance.
CT angiogram. We must know ourselves how to read.
Please.
Yeah, it is connecting now. Connected. देखो.
I think we don't have that attachment there. I guess he
No,
would
no.
have to. He will have to show an external camera.
No, it is going from here now.
Okay.
वो आपको ऑडियो विजुअल कनेक्ट करेगा ना उधर? हाँ, the screen is already there ना, projector.
Yeah. वो नहीं आएंगे. थक गया हूँ.
What happened?
कौन सी OT?
एक्सटर्नल कैमरास दिखा दो.
बस ये
इधर
फाइंड
लाओ.
अप करेंगे. दो चीजें बचेंगी. सर का SPL ligation और
यहाँ से सीधा बैंक्वेट थोड़ी ना था
यहाँ से आपको थोड़ा सा डिस्पर्स 7:30 तक बैंक्वेट. हम ऐसा चलना आपको जल्दी.
7:30 तक 8 o'clock तक
हाँ बिल्कुल.
ऑफिस बॉस को लेके आ जाओ.
हाँ बिल्कुल वो 9 बजे आएंगे. वो सीधे वहीं आएंगे.
वो सीधा वही
वो 9:30 बजे पहुँचेंगे.
Are you getting the picture?
Yes, sir, we can see. So,
what are you getting?
Audio converted to main screen.
Yeah, are you getting on the screen? सही आ रहा है? इसको क्या कर देना? पूरा कवर कर देना.
हाँ sir.
आ रहा है? This is
Please,
first video.
audio will please change to main screen.
Yeah, this is first video. 2 minutes video to show you the entire course of carotid artery to orient everyone.
Audio visual, please change PIP to main screen. कुछ ज़्यादा नहीं कह सकते. कोई कौन ओपन हो जाए.
Connected?
Yes, it is good.
Good. Now, just to show you the internal carotid artery course from origin to insertion quickly. First of all, see, this is a video to explain the things. This is the common carotid in the neck. Common carotid in the neck.
Right.
Now, if we remove all these muscles to show you, it's a very good video to explain. See, this is the internal carotid ascending in the neck.
Why? Yes.
See, this is ascending in the parapharyngeal space lateral to the nasopharynx.
Right.
And then goes into temporal bone.
Right.
This is carotid foramen in the temporal bone.
Yes, sir.
Now, as it ascends in the carotid foramen in the temporal bone,
Yes.
here is the jugular foramen.
Yes.
Now, where it ascends, if you look at the temporal bone, this ascends in the temporal bone medial to the styloid process.
Right.
This styloid process, then in a temporal bone, it has a small vertical course and a longer horizontal course.
Yes.
So if you see from here, it has a horizontal course like in the Peter's floor.
Yes. Yes, sir. Yes.
In the
sir, yes.
Peter's roof like this.
And
From
then move
here,
up.
horizontal, and it
Paraclival.
comes to the foramen lacerum.
Right.
This is the foramen lacerum.
Right.
It runs in the roof of the foramen lacerum where in the floor of the temporal lobe,
Right.
the brain, if you remove from above, you will understand. See this, the floor of the temporal lobe. See, this is the floor of the temporal lobe from above.
Yes.
Now, if the dura is removed,
Right.
see the dura is removed, what you see in the floor, the trigeminal nerve and its branches.
Yes.
You remove the nerve, you will see the carotid artery ascending through the foramen lacerum.
Perfect, sir. Perfect.
Then all the cranial nerves laterally, if you remove, see how the artery runs above.
Yes. And that genu is at the level of the middle ear.
Yeah, see, this is the
Cochlea.
posterior genu
Yeah.
in the cavernous sinus. Then it is
Okay.
the horizontal cavernous sinus. Then is the anterior band we have seen.
Right.
You see again. And laterally is the clinoid process. See this cavernous
Yes.
sinus?
Yes, yes.
How
yes,
it has a
perfect.
serpentine course in the cavernous sinus, horizontal.
Right.
And see this
There it
horizontal?
goes. Right.
Then anterior band like this.
The clinoid process.
Yes.
Part. Clinoid part.
Yeah, see this clinoid part. This is the clinoid part. This is the clinoid and carotid runs medial to it.
Right, right. Perfect. Perfect.
And then it comes above to the roof of the middle fossa,
And then circle of Willis.
sella, roof of the sella. See this artery comes above.
Yes.
And here it gives a retrograde branch ophthalmic artery.
Right.
And above is the optic nerve. See this ophthalmic artery runs above with the optic nerve. That's the optic nerve.
Right.
This is the ophthalmic artery running behind.
Right.
That's how the carotid artery has a course. Entire course from the neck to the brain, through the Peter's bone, through the floor of the
Amazing,
middle
sir.
fossa.
Amazing. This is amazing.
So you can understand easily the course of the carotid artery. Last thing about your CT angiogram, this is something we should know ourselves. So, अरे यार हटना. So let me show you a couple of examples. Open. You have to order angiography. Oh, come on. क्या हो गया इसको? Come on. Huh? I have a license, boss. What is showing? Diagram is not showing. How come?
बोलो बोलो क्यों
Funny.
अच्छा
Never happened.
तो फिर रुको
ये दिखता है.
मैं मृत्युंजय को बोलता हूँ मैं तुम्हें नंबर भेज रहा हूँ और मृत्युंजय को फ़ोन करके बोलो कि बस बोलना कि मैंने नंबर दिया है तुम्हें ड्रॉप कराना है
Rajat, I don't know what
Haji, sir.
happened to it. It is not opening. What I'll do, I'll show tomorrow. Tomorrow during the
sure,
talk.
sure.
Yeah, I think I have to do something to it.
Okay. So amazing session, sir. A big round of applause.
Thank you so much for your patience.
So for you to tell, I mean, today 1,000 people, including online, offline, saw you, sir.
Oh, thank you.
Yeah.
Thank you all.
Yes. So OT, can you please just shift here? So we'll be having an SPA ligation video by sir. Umang.